I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself, so it kind of opens my
research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself, so it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium? Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research.
Switch either mic.
So you're gonna do this, there's a lavalier.
Oh, the lavalier is hot? Okay. Yep.
Good morning, everybody. We're going to go ahead and get started. I just want to welcome everybody. Thank you so much for coming, taking time off of your busy residency careers to come and join us today. We're very excited to host this meeting. I want to thank OREF and the sponsors that you see behind me for allowing us to have this wonderful event here. Hopefully we will be a good host, and we'll go ahead and get started. We're just awaiting a couple judges, but we'll get started here in a second. Thank you so much.
Hi, good morning, everyone. I'm Lee Grossman. I'm the CEO of the Orthopedic Research and Education Foundation, OREF. I have some housekeeping matters to go over, and really appreciate us being here. This is a beautiful facility that you have here at Orlando Health, Jewett Orthopedic Institute, and it's a pleasure for OREF to certainly be here and have such gracious hosts as yourselves. So this is our second Resident Research Symposium of the year in 2026. We've been doing this for 23 years? 23 years, and it's been one of the signature events of OREF that we've done every year. So as I said, this is our second one of the year. We've done one already this year at Washington University in St. Louis. We have one coming up at University of California, San Diego, a combined Johns Hopkins and University of Maryland symposium in Baltimore later this year, and then the last one will be at NYU. In November, we will have our National Resident Symposium, where the winners of the regionals will compete for a grand prize. This is being broadcast live, so for all of you, when you're asking questions or you're up here taking questions from the judges or doing your presentations, please speak into the mic so that the people watching live will be able to hear you. The presenters today, you're divided into 5 sections. And the moderator will introduce each speaker. Once you're done with your talk, please sit in the front, because when your section is finished, you'll come up on the stage and we have a mic that will pass around, and the judges will be asking you questions. So the way this will work is that we have a presenters award. So please, all of you in the audience, pay attention to the presentations. You have an opportunity to judge your peers. The person with the highest score from all of the presenters will receive a cash award. We have 3 categories of winners. We have 3 third-place winners, 2 second-place winners, and 1 first-place winner. And again, they receive cash awards for their presentations today. The second place winners and the first place winners will go on to compete in the national symposium that we're having on November 18th. It's done virtually, so you don't have to travel for that. And the grand prize winner of that of the national will receive a prize for an all-expense paid trip to the Academy meeting in March in Las Vegas. When you're finished, when each section is finished, please make sure that you fill out your sheets. The judges, please fill those out and hand them to Carmen, who's down, and you probably met her when you registered this morning. Anyway, that's it for the housekeeping. Let me go over a little bit about OREF and who we are. But before I start my remarks here, I just want to acknowledge the passing of a great human being who's past president of OREF, Dr. Urbanek, who passed away last month. He was a great family man, a great researcher, leader, mentor, and he sorely will be missed. So I want to thank Orlando Health and Jewett Orthopedic Institute for hosting this today, and our host and keynote speaker is Dr. Schath, and appreciate you spending your time and energies to put this on for us. Also want to thank our judges, Dr. Ahmed, Dr. Green, and Hajdukovic, for coming here and judging our presenters today. We can't put these symposium on without the help from our industry sponsors, and we're very, very grateful to Zimmer Biomet, DePuy Synthes, and Smith+Nephew for their support. And lastly, we have to thank the Hark Family, who is a family foundation who has been supporting our symposium for decades now, and we're, again, very grateful for their generous support here. So what is OREF? Now, OREF has been around for over 70 years. We were founded in 1955 when the American Academy of Orthopedic Surgeons, the AOA, and the ORS came together and said, we need to find a way to promote clinical research. Because at the time, there was a dearth of clinical research that was being presented in orthopedics. So they came together and they put OREF together. And it's always been here. It was created by orthopedic surgeons for the orthopedic surgeons to find an avenue to come with the highest quality research and present that, and then with the help of OREF to hopefully go on to get greater funding and to support your careers as clinical scientists. We've awarded $4.1 million in 2025. Of that, about $1 million of it was new funding, and the rest was what we paid out in our active grants. One of the things that we're most proud of is the fact that we're nurturing the pipeline of new clinical investigators. That's a very, very important role of what OREF does, and is what we're most proud of. We see ourselves as a unifying force. When those three organizations came together to form OREF, that was one of the things that they wanted OREF to accomplish, is that it would represent all aspects of musculoskeletal research, and that it would be moving forward together in innovation and research. And as Dr. Urbanek has always said, that OREF is the heart of orthopedics. We are 100% supported by donors, and because of that, we're able to be independent. So we're not subject to special interests. We can go out and do surveys, find out what the highest priorities are in all the specialties, and try to fund those highest priorities to move the research forward and the innovation forward. It's one of the principles of OREF that we are independent, and we have a very, very rigorous peer review process as a result of that, so that we are funding the highest levels of research and clinicians and supporting them through their careers. We're also very collaborative. We collaborate with over 60 organizations. And as you can see from this graph, is that on the pie chart, we're essentially funding all aspects of musculoskeletal research. We have supported over the last 5 years almost $800,000 in resident research and education. And we have raised money and support other specialty societies and our 60 organizations that we collaborate with over $4 million that we've given to them. Our total mission support over this period has been over $25 million. We really enjoy the support of the donors from the orthopedic and the orthopedic surgeons from departments. That is one of the main ways that we fund our research. Again, we're very grateful to those orthopedic groups that support us, and maybe Orlando Health and Jewett Orthopedic Institute can be one of those. When you look at our impact, we're very, very successful in having those grants that we fund move on to greater federal funding. Essentially, about 20% of what we fund goes on to greater federal funding. And our career development grants, over half of those go on to receive federal funding at about 5 times what the initial grant is. So we've been very, very successful in doing that. We're also, there's been research out in journal articles published on how we develop future clinical scientists. Of the people that are in this room that receive resident grants, about 64% of them go on to academic careers. So we are supporting that very well. We've have a great history of funding initial studies that have resulted in changing clinical practice. And this is just a very, very small sampling of some of the research that we have funded over the years that are part of what you're doing on a day-to-day basis that started out with an OREF grant. One of which is, that's not listed here, that we're really proud of is Dr. Tom Faring just got published his study, and Dr. Green was part of that, where we looked at 1-stage versus 2-stage revisions for PJI, and feel that that is having a major impact on clinical practice today. So one of the things that I want to finish this talk on is looking at OREF as a unifying force in orthopedics is one of the initiatives that we've taken the lead on. And that's trying to address the burden of musculoskeletal disease as compared to the amount of funding that's available for research. As we all know, MSK dominates healthcare. It is in procedures and in dollars, it is the largest aspect of our national healthcare system. And yet it receives among the lowest amount of funding of all the major disease conditions. And it's been that way since 1955 when we were first founded, and it's even more so true today. So we got together with ORS and the American Academy of Orthopedic Surgeons and said, we have to do something here. This is getting even more critical. Our funding levels are being challenged. Last year with the federal funding cuts, it seemed as though MSK research was an easy mark to cut, and we lost a lot of our funding. Some of it was clawed back, but not an adequate amount. So we decided to come together and try to find a way that we can bring all of orthopedics together, patient advocacy groups, industry, all the stakeholders, so that we can raise awareness about MSK and make it a national health priority. And so in December, the group ORS, Academy, and OREF got together, brought in leaders from 10 other orthopedic societies, patient advocacy groups, and industry to have the summit. What came out of the summit was ways for us to look at how we can coordinate among the orthopedic societies and even patient groups to look at what research is being done, what synergies could be established between the organizations, so we can create grants that are more significant, more impactful, and much larger, and capitalize on what each has to offer. So that's one of the things that we're doing. We're also putting together a coalition of groups that will begin to work on a national campaign to bring awareness to MSK issues, because we feel very strongly that our national healthcare system will not improve until and unless MSK issues become a national priority. So we're working on that. Since December, we've talked with over 20 orthopedic societies, 10 patient advocacy groups and industry. We're about to get some white papers published in the journals so that we can get awareness out among the community. And the patient advocacy groups are very excited about what we're leading forward. So we feel very strongly that the path forward is collaboration. This was a picture from the group that attended that. We had also the director from NIAMS there who gave a very impassioned talk about how we need to collaborate and move this forward to make it a national priority. So with that, thank you very much for being here. Please support OREF. We're the only organization that is committed solely to funding research in all aspects of MSK. And what it's a unique opportunity when you do donate to OREF, because that money has a direct impact back to your patients and to your practice. So good luck today, residents. We're looking forward to your talks, and thank you for your attention.
All right, we'll go ahead and get started. Dr. Stoy will be talking to us about long-term outcomes of shoulder arthroplasty for humeral head avascular necrosis. Dr. Stoy.
All right. Good morning, everyone. My name is Conrad Stoy. I'm coming from Tampa and USF and FOI. I'm here to talk about long-term outcomes of shoulder arthroplasty for humeral head avascular necrosis. So avascular necrosis is an uncommon and heterogeneous. And our question was, does the cause of the necrosis change what happens after arthroplasty? And the short answer is in the title: the etiology drives function, physical status drives mortality. So the background, the humeral head is the second most common site of avascular necrosis, only behind the femoral head. It's divided into traumatic and atraumatic etiologies, and most series lump together the etiologies together or compare atraumatic versus post-traumatic, although nobody has compared idiopathic against known systemic causes for patient-reported outcomes. And the two studies that reported mortality did so descriptively, and so our aim was to evaluate how avascular necrosis etiology influences functional recovery, implant survival, as well as mortality. So this was a single surgeon, single institution retrospective review from 2003 to 2023. The final cohort comprised 51 shoulders and 42 patients with atraumatic avascular necrosis confirmed on preoperative imaging in patients that underwent totals, hemis, and the primary analysis was a Kaplan-Meier for revision and death. We utilized a multivariate logistic regression for mortality and a linear mixed effects model for ASES scores, STT scores, and range of motion in the 31 shoulders with at least 1 year of follow-up. A post hoc cruise grade was then sensitivity analyzed. Sensitivity analysis was performed by two blind graders on subsequent analysis. And this was a middle-aged cohort. The mean was approximately 55 years. With the majority being female. 17 shoulders comprised the idiopathic group, whereas 34 had a known cause, predominantly steroid use. However, there was HIV, sickle cell, caissons, and chemotherapy. The comorbidity, note that the comorbidity burden was nearly 3/4 were ASA grade 3 or 4 in our cohort, and there was no baseline difference in cruise grade between the two groups. In our model of ASES over time, the idiopathic shoulders started at 27 ASES points below the known etiologies, but they improved by 0.85 points per month faster. The model group gap closes to about 17 points at 1 year and 6.5 points at 2 years. So the curves did cross at this point. We saw the same pattern in STT, forward elevation, abduction, and external rotation. Internal rotation was the only outcome that didn't significantly differ by etiology. There were 5 revisions among our 51 shoulders. Revisions-free survival was 95% at 1 year, and 98% at 5 years, and then 82% at 10 years. We found no difference by procedure or ASA group, but with only 5 events, the subgroup comparisons are exploratory and underpowered. And then this is the finding that may change in practice. There were 10 deaths among our 42 patients. Overall survival was 86% of the cohort at 5 years and then 80% at 10 years with 76% at 15. Every death occurred among the high ASA group. In the multivariate regression, ASA was the only independent predictor of mortality, with each 1 point increase carrying a 13.5 fold increase in the odds of death. The confidence interval was wide because there were so few deaths among our cohort. And so this would be more hypothesis driven versus conclusive. The idiopathic patients were as likely to have ASA 3 or 4. So etiology is not a proxy for is not necessarily a proxy for physiologic risk. Obviously, there's some limitations being a retrospective analysis and single surgeon cohort. The patient-reported models rest on a subgroup of 31 shoulders, so the results are exploratory as discussed. We pulled the known etiologies into one heterogeneous group, which may hide etiology-specific factors between steroids, HIV caissons, and other known factors. And with only 5 revisions, these subgroup comparisons are slightly underpowered. The take-home points from this study are that idiopathic AVN starts with a lower function pre-op, but tends to climb faster in the acute to subacute phase of recovery. So these patients can be counseled differently on their trajectory rather at their first visit. Every death occurred in the high ASA group, and ASA was the only independent predictor of mortality. In the ASA 3 to 4 patients, systemic health rather than implant is the limiting factor, and so the procedures with the most predictable early function are probably the better choices for these patients. Thank you.
We'll move on. Dr. Hodgins from Carolinas Medical Center will talk to us about implant position and tuberoplasty effects on range of motion and reverse shoulder arthroplasty.
Thanks, sir. Good morning, everybody. My name is Blake Hodgins from Carolinas Medical Center in Charlotte, and I'll be talking about impingement-free range of motion in reverse shoulder arthroplasty. So reverse has excelled in the categories of pain relief and reestablishment of functional elevation. However, one area with high variability postoperatively is range of motion, which is directly correlated with patient satisfaction. We're all familiar with the concept of scapular notching. However, with more modernized reverse implants that have a medialized center of rotation, a new problem has arisen, which is subacromial impingement or subacromial notching. When we look at the determinants of range of motion following reverse, it comes down to 3 categories. That's implant design, implant positioning, and then the patient's native bone and resultant bony impingement. And at this time, the combined effects of implant positioning and this native bone and bony impingement is incompletely defined. So this concept of targeted bony resection was actually popularized out of France by Dr. Belot and colleagues, where they investigated the role of acromioplasty and found improved and positive impacts in terms of impingement-free range of motion following reverse shoulder arthroplasty. So since acromial-sided strategies appeared to be effective, it led to the question of whether an isolated humeral-sided strategy would have similar results. The proposed benefit of an isolated humeral-sided strategy would be that you're not thinning the undersurface of the acromion, so you mitigate any risk of stress fracture, and you don't cause any deltoid origin morbidity, which is of utmost importance of patients who have a dysfunctional cuff. We performed a retrospective review of a multi-center international database. This was the Advita preoperative planning software of patients undergoing primary reverse shoulder arthroplasty for all indications. We created this standard build, which was then modified with various humeral and glenoid-sided manipulations. This included changes such as base plate distalization, introduction of base plate inferior tilt, as well as humeral lateralization by increasing the polyethylene thickness. We then performed a virtual tuberoplasty, which was a standard 5 millimeter resection of the greater tuberosity bone with the use of a virtual burr. The shoulder was then taken through range of motion through various planes. And this impingement-free range of motion was measured and recorded as the total degrees prior to impingement, which is signified by the presence of a red marker in the preoperative software. With the addition of this virtual tuberoplasty, pre-impingement range of motion significantly improved in all planes postoperatively. In abduction, it improved by 10 degrees. And then in forward elevation, there was significant improvements as you increase the degrees of external rotation, going from 10 to 30 to 45. A unique and novel aspect of our study is that we were able to identify the exact location of both humeral and acromial-sided impingement throughout these various planes and created this novel classification system that would hopefully guide intraoperative bony resection. Inferior base plate placement and tuberoplasty both produced significant, meaningful improvements in impingement-free range of motion compared to the standard build model. Inferior base plate placement improved range of motion by 36 degrees, and tuberoplasty improved range of motion by 30 degrees across all planes of motion. So how can this be used in clinical practice? You can see here, this is actually a standard Part of the procedure that we perform in Charlotte, where an intraoperative tuberoplasty is performed with the use of a large rongeur during the trialing part of the procedure, where the humerus is dislocated in adduction, external rotation. The patients to keep in mind, rotator cuff arthropathy, they already have cranial migration of the humeral head abutting the undersurface of the acromion. They're at early risk for clinical impingement. Those who have an elevated critical shoulder angle, this was described by Dr. Sewall and colleagues, can be measured preoperatively, a degree of greater than 31 degrees. They're significantly more likely to have early clinical impingement. And then finally, during the trialing aspect, when you're moving the shoulder through the range of motion, if you're visualizing early impingement despite adequate implant positioning, this may be a good candidate for intraoperative tuberoplasty. So as tuberoplasty is an emerging concept, the potential negatives at this point in time are unknown. That includes the morbidity in patients who have an intact cuff, whether this technique is even possible in those who undergo a subscapularis peel or lesser tuberosity osteotomy. And then finally, we don't want to introduce iatrogenic instability by taking away too much proximal bone, where we lose the effect of the deltoid wrap. So range of motion after reverse is multifactorial, but it's becoming increasingly important. Impingement-free range of motion is shaped by both implant positioning as well as the proximal humeral bone morphology. And tuberosity impingement is predictable, and tuberoplasty may be a low-risk solution. Thanks to the tuberoplasty team. Thanks for the opportunity.
We'll move on. Just a quick change to the schedule. Logan Reed will be presenting early on preoperative MRI-derived navigation, reducing radiation exposure, and pediatric spinal fusion. Dr. Reed.
Hey, I'm Logan Reed. I'm a PGY4 here at Orlando Health. I'm going to be presenting on preoperative MRI-derived navigation reduces radiation exposure in pediatric spinal fusion. So as a background, we know that spinal navigation has reduced the rate of postoperative neurological injury, but it does come at a cost. It does require a CT scan, which does emit radiation. We can attribute this radiation to on excess 5,500 cancers every year in pediatric CT scans. This in turn, one CT scan can increase the rate of bloodborne cancers in pediatric patients by 30%. So the purpose of our study was to determine if MRI-derived navigation or synthetic CT scan can eliminate this preoperative CT, decrease radiation burden, all while maintaining similar safety profiles in patients undergoing idiopathic scoliosis pedicle screw insertion. So we separated groups into fluoroscopy, CT navigation, and synthetic CT navigation using our protocol. So what is synthetic CT scan? Essentially, we use machine learning or AI to generate a CT image from a preoperative derived MRI. We then upload this to a navigation-based software and use it for pedicle screw placement. As you can see here, this is just a standard MRI. We then use the algorithm to convert it to a synthetic CT scan so the patient never has to undergo any radiation. And then we can even reconstruct it into a 3D model based off this synthetic CT. So this is a retrospective cohort of patients undergoing posterior spinal fusion for idiopathic scoliosis. It was done by 2 fellowship-trained pediatric orthopedic surgeons. Screw trajectories were planned and executed using optical tracking, and then fluoro was confirmed for pedicle screw placement and then rod correction at the end of the case. So for results, we had a total of 94 patients broken down between 39 in the fluoroscopy group, 28 in the CT group, and then 27 in our synthetic CT protocol. There was no differences in demographics or operative parameters between the groups. So for fluoro time, intraoperatively, we were able to decrease it by 50% when compared to the navigated groups, and then total radiation decreased by 40% in the navigated groups. Importantly, and this is kind of the meat of the study, there was no preoperative CT scan that the synthetic CT patients underwent. So on average, we eliminated 19.5 millisievert of radiation per patient. This is equivalent to 230 chest x-rays or the annual occupational exposure for nuclear energy workers. You're probably asking, is this technology accurate? So we used optical tracking And intraoperatively, you're able to topographically map the spine and make sure that it was accurate intra-op at 3 to 4 levels, and then we'd continue up and re-register. To date, none of our synthetic CT protocol patients have had any neurological complications or screw malposition. So what's the novelty of this procedure? We're the first hospital in the world to use this technology and publish on it for pediatric spine surgery. We just published on it in the Journal of Pediatric Orthopedics this last month. So main takeaways, synthetic CT navigation eliminates preoperative radiation. It decreases substantial total radiation. Navigation significantly reduces intraoperative radiation. And this is all while maintaining safety profiles. This is the future of spine surgery, and it's the next step towards a radiation-free and safe spine.
All right, back to the shoulder. We have Jackson Hammersley, glenoid morphology in patients undergoing reverse total shoulder arthroplasty due to fracture. Dr. Hammersley.
All right, good morning, everybody. I'm Jackson Hammersley. I'm one of the twos here at Orlando Health. Welcome, everybody who's coming from out of town. So quick intro, when we think of geriatric fractures, we think of hip fractures, distal radius fractures, and then proximal humerus fractures being one of the most common ones. Typically, when we see this in the ED here at Orlando Health, we get a CT scan to evaluate the severity. Typically, this is focused on the humeral side to determine how many parts it is when we think of the classic classifications. And then that helps us determine operative versus non-operative management. So going down the spectrum of management here, we can put them in cuff and collars. We can do open reduction, internal fixation, hemiarthroplasty, and more recently, reverse shoulder replacements are more common. So the purpose of our particular study was to characterize the glenoid morphology in patients undergoing reverse shoulder arthroplasty for fracture in particular. The goal of this study was, we were thinking that it would allow surgeons performing this surgery for fracture to better predict the morphology of the patients that they're undergoing. Our method, so we had is a retrospective review of reverse shoulder arthroplasty done from 2015 to 2023. All patients had to have a preoperative CT scan, and then we used the Friedman line to assess glenoid version, the RSA angle to assess inclination. These were measured by MSK radiologists as well as shoulder and elbow trained orthopedic surgeons. And then for glenoid morphology, we used the commonly used Walsh and Favard classifications. So after all patients were excluded, we had 53 patients. This is an example of the Friedman line and the RSA angle. Friedman measured on axial CT, and then on coronal CT, we can get the RSA angle. The Walsh and Favard classifications are commonly used. Walsh classification is used in the axial plane, and then Favard classification is coronal plane, more commonly used in cuff arthropathy. Our demographics, as said before, we had a total of 53 patients. The mean age was 70. We had 85% females, and then 15% male. 74% had pre-existing arthritis. When we look at how we break it down, particularly in morphology, we had 49 patients that were classified as Walsh 1A, and then 52 patients as Favard E0, which indicates that there is relatively little deformity of the glenoid. As far as for our measured version and RSA angles, the mean degrees of retroversion for all of our patients was 3 degrees, and then our mean RSA angle was 19 degrees. And then on the bottom here, we can see that we had talked about previously how they were measured by MSK radiologists as well as a shoulder elbow trained orthopedic surgeon, and these were equivalence tested and deemed to be equivalent. So conclusions for our study was that the rates of cuff arthropathy or severe arthritis is relatively low in patients undergoing reverse shoulder arthroplasty for fracture. Preoperative CT scan is recommended not just for the humeral side to determine how many parts in operative versus non-operative treatment, but also to plan for your reverse shoulder arthroplasty in regards to the glenoid morphology. Limitations are that it was retrospective. It was a relatively small study with only 53 patients. We only characterized proximal humerus fractures that went on to receive a reverse shoulder arthroplasty, so we did not characterize the non-op glenoids. Obviously, that would be potentially a different patient population. And then humeral head position is often considered when characterizing the glenoid. And obviously that's harder to do when we think about these 3- and 4-part fractures that are undergoing reverse shoulder arthroplasty. And then there were no patient-reported outcomes that we included in the study. And there it is. Thank you, guys.
Next, we have Dr. Encinas talking to us about clinical outcomes and complications, profile of open and arthroscopic ankle arthrodesis, a systematic review.
Good morning, everybody. I'm Rodrigo Encinas. I'm a PGY4 here at Orlando Health. So today I'll be presenting clinical outcomes and complication profile of open arthroscopic ankle arthrodesis systematic review. So as we all know, ankle arthritis and ankle pain is one of the most common sources of pain in the population. And one of the gold standards have been ankle fusion in the past, still today, one of the main surgeries. And in orthopedics, minimally invasive surgery has gained a lot of popularity. So the goal of this review was to check comparative studies that reported on both MIS and on open ankle arthrodesis, both the complications and outcomes. So for our methods, we use PubMed and based on the Cochrane library for our databases. We had no day restrictions, no patients below 18 years old. We excluded any TTC or subtalar arthrodesis. And we had a total of 561 results and only 19 studies met our inclusion criteria. The key part here is that we only included studies that directly compare both techniques. These are Prisma flow diagram with the search. So our results, we had 19 studies with a total of 1,554 arthrodesis. There were 719 that were open, 835 that were MIS. There was no significant difference on age among groups or BMI, and the average follow-up was slightly over 3 years for both groups. Our main findings was that we found a significant lower wound complication and infection rate for the MIS group with 1.1% versus 8.5% in the open group, and also a shorter hospital stay for the MIS group with 3.3 days versus 5.4 days. Our union rate did not reach significance, but it was 91.2% in the open group and 94.9% in the MIS group. Duration of surgery for the open group was 125 minutes versus 119 minutes for the MIS group. They didn't reach significance, but also worth mentioning. And there were no any other significant difference among both clinical outcomes or complications among both cohorts. So in terms of our limitations, this is a retrospective review, so it has inherited risk of bias. We didn't have any randomized controlled trials. Most studies were level 3 and level 2. We did not complete an analysis on special patients with deformities, diabetes, or other medical conditions. And we also had less than 1,000 patients in each group, which could affect the power of the review. So in conclusion, both open and MIS ankle arthrodesis have good outcomes. They're safe. However, in this review, we found that the MIS group had lower infection rate, wound complication, and shorter hospital stay with significance. And also another area that is usually discussed and is a problem with MIS is surgical time that may be more and union rate. And this review didn't find any difference surgical time, union rate, and revision surgery. And that's the link and the QR code for the full paper. Thank you.
All right. Do you guys have any questions for our presenters?
Logan, hey. So with your study, did you guys look at costs?
Yeah, so that's a good question. The initial upfront cost for the software that we use, which is bone MRI, is $45,000 per hospital. It's not each MRI cost. It's just the software system for the entire hospital. But if you factor in eliminating all CT scans over, you make your money back in like 20 or 30 patients. So we already made our money back.
A question for Logan as well. Is this a special sequence MRI, or can any old MRI they bring be reformatted
It has to be there's a certain protocol. It's certain cuts they have to have. And the software company provides that sequence, and you can just, any MRI machine can do it though.
Rodrigo, in your guys' study, what was an MIS? What procedure exactly was that? How was it done? Arthroscopic, like little mini open?
Yeah, so all of them were arthroscopic, and they did usually the anterolateral and anteromedial portals. So they did all the joint preparation arthroscopically, and then they did 3 screws percutaneous usually. And for the open group, there was a mix between anterior and lateral approaches.
Thanks.
Question for Dr. Hodgins. Are you guys doing this tuberoplasty? The study that you showed was mostly just machine study, but are you guys doing it? Do you have any clinical data?
Yes, sir. So the study that I presented today was all based on preoperative planning software, which is kind of phase 1 of our study. We actually are collecting clinical data now of patients that we're doing tuberoplasty on. This is something that a couple of my mentors in Charlotte have been doing for many years, but have just not, collected any formal data on yet. So we're in the process of that, and that would be the hope, is to basically randomize patients to tuberoplasty versus non, and see how they do clinically.
A similar question is, are you looking at acromial morphology before you make a decision to decompress on the tuberosity side?
So nobody in Charlotte is doing an acromioplasty.
Regardless of the shape of the acromion.
That's right. Yeah. So we're mostly focusing on humeral sided strategies, mostly for the fact that, the dreaded complication is that acromial stress fracture, not wanting to thin it out. That is one area that I would bring up as a limitation of our study within the preoperative planning software. There's no data as to whether these patients may have had a prior subacromial decompression in the past, which oftentimes patients who are undergoing reverse maybe 20 years after a prior rotator cuff repair. So that's certainly something to keep in mind with our data as you interpret it as well.
Hey, Conrad, for you guys, did you compare to just standard osteoarthritis? I know you did AVN to AVN.
So this cohort was specifically looking at AVN indications for surgery. We have not compared it to like primary OA or any other etiologies, but that's a future direction.
Yeah, it'd be nice to see a comparison, at least in the total joint world. Like,
Yeah.
we'd like to know what complication rates are comparison. So not knowing any of the shoulder upper extremity stuff, it'd be nice for us to see the comparison.
Yeah. This one was purely focused on the avascular necrosis cohort, but future directions for sure.
What was the main reason for revision in that cohort? You had a relatively high revision rate at 5 years.
Yeah, at 5 years, the main reason for revision was base plate failure. There was one for infection, and then I think the rest were base plate failure.
Yeah, to Cody's point, it'd be great to match it 2-to-1 to, but you got to match. You have a high comorbidity index on those patients, so you'd have to find those.
Yeah.
And then do a 1-to-1 or 2-to-1 match.
Yeah.
We'll move on to the trauma section. Dr. Kucharik from USF will talk to us about mortality after operative proximal humerus fractures is associated with age and baseline ambulatory status.
All right, thank you everyone for your attention. So fragility fractures can be a sentinel event, proximal humerus fractures in particular. We know they're very common in older adults with osteoporotic bone, and they're associated with frailty and functional decline. And the outcomes in the literature may also be biased due to incomplete follow-up. That's something we see in the trauma population in general compared to the elective arthroplasty population. So the purpose of our study was threefold. Number one, we wanted to evaluate mortality after operative treatment of proximal humerus fractures. We wanted to identify predictors of mortality and complications. And we also wanted to characterize loss to follow-up because we know that this cohort does not follow up as regularly as other cohorts. So within Florida Orthopedic Institute, which is where I go to residency, we looked at 459 consecutive proximal humerus fractures that were treated operatively from 2021 to 2024. 60% of these were treated with fixation, which was either an intramedullary nail or OREF, and then 40% were treated with arthroplasty, which was either a reverse or a hemi. And within that cohort, we captured all comorbidities, medical comorbidities, but one comorbidity that we also wanted to look at was whether they were assistive device dependent, being a walker or a cane, and 14% of those did have some kind of dependence on a assistive device. So outcomes, the primary outcome was all-cause mortality, secondary outcome was 90-day complications, and then the tertiary outcome was loss to follow-up. So for results, the 90-day mortality in this cohort was 1.6%, the one-year mortality was 5.9%, and the all-cause mortality throughout the duration of the study was 8.7%. And within a regression analysis, which was controlled for medical comorbidities, age and baseline ambulatory status independently predicted mortality. And if you look at this stratified here, so patients who were over the age of 65 and they had an assisted device had a 34.5% mortality rate throughout the duration of this study, versus those that were independent ambulators and were younger than 65 years old had a 4.5% risk of death. So about an 8-fold increase if they were older and used an assistive device. In terms of complications, the overall complication rate was 20.7%. Reoperation occurred in 8.5%. And among those, the majority was revision from OREF to a reverse. And there were no independent baseline predictors that were identified here. And then in terms of follow-up attrition, so we looked at the attrition of these patients coming back to our clinic at 6 weeks, 3 months, and 6 months. And there, as you could see, the follow-up declined over time. About 23% were lost to follow-up within 90 days. And looking at the follow-up rates by procedure, age, and sex, so fixation patients versus arthroplasty patients were independently predicted to be lost to follow-up. And then looking at younger age and male sex were also associated with loss to follow-up as well. And then we also looked at social determinants of health, so area deprivation index, which is based on their zip code. So the more deprived patients were associated with a higher follow-up attrition. So they were more likely to be lost to follow-up. Limitations of the study was a retrospective study. We weren't able to stratify based on injury severity because of the limited preoperative x-rays that were available. Obviously, outside events may be missed. Our practice takes call at various hospitals across the Tampa Bay area, so we didn't have EMR access to all of them. And loss to follow-up was significant within the study, but that was also one of our aims. But take-home points, so ambulatory status serves as a measure of fragility. The 90-day mortality for this cohort was 1.6%, and the one-year mortality of 5.9%, obviously a lot higher than those that required assistive devices and were also older. Complications were much more difficult to predict, and they were also multifactorial. And the follow-up attrition differs from predictors of mortality. So we may actually, the complications may be higher in those groups that we were missing in follow-up. And obviously next steps were to look at interpret the outcomes in the fracture populations, but we also have to understand that it counts for non-random loss to follow-up. Thank you.
Next up, we have Dr. Brennan Page, a dual approach to Vancouver C femur fractures, improved outcomes with retrograde nail and lateral plate fixation compared to lateral lock plating.
Hey everyone, thanks for being here. I'm Brendan Page. I'm one of the PGY5s here at Orlando Health. Talking to you about Vancouver C fractures. So Vancouver C periprosthetic femur fractures are those that occur distal to a femoral stem. They're typically treated with osteosynthesis in comparison to Vancouver B fractures, which often require revision arthroplasty. Historically, these have been treated with lateral locking plates alone, followed by a period of protected weight bearing. These Vancouver C fractures represent a heterogeneous group. They can be either diaphyseal just distal to a stem or also distal metaphyseal closer to the knee joint. In these geriatric populations, there's been a recent push to incorporate intramedullary devices to allow immediate weight bearing and help distribute strain across these constructs. So the aim of our study was to compare lateral locking plates versus retrograde nailing with a minimally invasive periprosthetic plating system in the management of these Vancouver C periprosthetic fractures. So for our retrospective review, we took all adult patients who sustained a Vancouver C fracture over the course of 6 years at our institution. Patients were grouped based off of the fixation method used, either a lateral locking plate alone or a nail plate combo. With regard to the lateral plating, There was a minimally invasive small subvastus approach that was done distally at the knee joint, and then the plate was placed percutaneously up the femoral shaft. So for inclusion, we required 1 year follow-up, documented radiographic union, or reoperation, one of the three. The primary outcome was radiographic fracture union in the absence of clinical pain with full weight bearing. Secondary outcomes that we looked at were implant failure, deep surgical site infection, or malalignment at final clinical follow-up. So our results, we had 52 patients total, 30 in the nail plate group and 21 in the lateral locking plate group. Similar demographics across groups. Mean clinical follow-up was 7 months and 12 months respectively for the groups. And the fracture classifications were similar between the two groups. In our nail plate group, we had a median nail diameter of 12 millimeters and 240 millimeters of length. There were 5 screws distally and 4 screws proximally in the plate. No cerclage wires were required. And we had a normal lateral distal femoral angle at immediate and final follow-up for this group. There was no malalignment seen in this group, and all fractures healed without implant failure. In our lateral locking plate group, there was an average of 6 screws distally, 4 proximally. Cerclage was required in 6 patients, and malalignment occurred in 3 patients. And those were contributing to the 3 non-unions that occurred in this treatment group. So on the complications, in the nail plate group, there were 2 patients that required interlock removal, and then 3 patients that went on to malalignment in the plate group, and those were also contributing to the non-unions. There were no infections in either group. The image on the right is an example of a patient that was treated with a lateral locking plate alone that went on to a non-union, was subsequently treated with a nail plate construct and went on to a radiographic union at final follow-up. So the nail plate group appears to demonstrate a superior union rate compared to the lateral locking plate group with immediate post-operative weight bearing. The introduction of an intramedullary device likely distributes strain across the construct and enhances axial and rotational stability to promote immediate weight bearing and fracture healing. Our limitations, it was retrospective design, kind of a modest sample size, and then we had a low overall complication rate, so tough to draw complete conclusions from that. So in conclusion, the nail plate construct facilitated early mobilization without compromising alignment or implant integrity, and is associated with a lower rate of non-union. Some references. Thanks for listening.
Next up from Greenville, we have Dr. Flores, outcomes of operative versus non-operative treatments for tibial plateau fractures.
Good morning, everyone. My name is Cassie Flores. I'm coming from Greenville, South Carolina. This morning, I will be discussing operative and non-operative management for tibial plateau fractures. No disclosures for relevant work. The purpose of our study was to compare patient-reported outcomes between operative and non-operative groups of tibial plateau fractures that were propensity matched by Schatzker classification. The study was performed as a retrospective comparative cohort study. We included patients between the ages of 18 and 80 years old with isolated tibial plateau fractures between the years of 2016 and 2024. Patients were identified by the CPT code at our institutional base. Demographics of the injury, comorbidities, and patient characteristics were collected. Patients were excluded if they were non-ambulatory at baseline. We classified and propensity matched by Schatzker classification. Patients were called at approximately 1 year following injury to complete patient-reported outcome studies, including the WOMAC, the Lashom knee score, PROMIS physical and mental, as well as looked at Rasmussen tibial plateau, just the specific imaging comparison following about a year. We use the Schatzker classification to classify our patients. We deem types 1, 2, and 3 as our lower energy or simple fracture pattern, as well as types 4, 5, and 6 as our higher energy or more complex fracture patterns. And we use these to compare our outcomes. So we had 40 patients that were included, 20 in the non-operative group, 20 in the operative group, 15 were in each low energy and 5 in the high energy group. Overall, our age, there was a younger age in our operative group that did meet statistical significance. Our groups were balanced and propensity matched between high energy and low energy on the Schatzker classification. However, our subtypes did differ, that did meet statistical significance between the specific Schatzker classifications. There was no significant difference in BMI, smoking, diabetes, or gender through our groups. Overall, patient-reported outcomes on average were higher in the non-operative groups in the Lishome, the Promise, physical and mental, and then the WOMAC is an inverse, so the lower score actually meant higher functional outcomes. Overall, they trended to be higher from a functional standpoint in the non-operative group, however, did not meet statistical differences. The Rasmussen scores were essentially equal in both groups. We did have one non-operative patient that ultimately underwent a total knee arthroplasty within 6 months of non-operative management. None of our operative patients underwent further surgical intervention. In conclusion, when controlling for severity by the Schatzker classification, operative and non-operative management of tibial plateau fractures showed no difference in patient-reported outcomes at 1 year. Obviously, further investigation necessary to determine long-term outcomes, reoperation rates, and non-operative failure. Thank you.
All right, next up, we have Dr. Meyer from Orlando Health talking about intra-articular air, predicting hip joint instability following posterior wall fractures, irrespective of fracture size or history of dislocation.
All right, morning, everyone. I'm Jake. I'm one of the BJY2s here. Thank you for being here. So a little background, posterior wall acetabulum fractures are the most common acetabular fracture pattern. Hip instability following these fractures can be difficult to predict. We know from previous research that fracture size alone is unreliable. As with some fragment sizes of only 9%, they've been found to be unstable. EUA is the gold standard for determining stability of these fractures. However, they do come with a theoretical risk of the anesthesia for the patient, as well as the cost of an OR time. And in a busy OR schedule, sometimes that can slow you down. So the purpose of our study was to see if the presence of intra-articular air on injury CT scan would correlate with hip joint instability and therefore be a better indication for you to perform an EUA. This was a retrospective review. We had 71 patients in total who had an EUA. This was conducted at 2 level 1 trauma centers, and we had 2 groups, stable hips, EUA positive, and unstable hips, EUA negative. Primary outcome, of course, was intra-articular air on CT, and then we also measured or gathered data on history of dislocation, fracture size, displacement, sagittal angle measurement, and fracture distance below the dome. So our results here, we see that in the unstable hip group, there was a high percentage of patients with intra-articular air in that group, as well as evidence of hip dislocation on injury radiograph, sagittal angle greater than 70 degrees, fracture displacement greater than 5 millimeters, and the average calculus size or fragment size when measured by the calculus measurement. When we break things down based on fracture size alone, we see that there's no significant difference between the stable and unstable groups, except for the one group using measurement, the calculus measurement for fracture fragments less than 20% of the posterior wall. When we break things down based on hip dislocation, we see that, as you might expect with a history of hip dislocation, there's a higher percentage of patients who had evidence of intra-articular air on CT scan. And
it's not pointed out here on the slide, but this intra-articular air is coming from that vacuum phenomenon when you break the capsule. Something interesting, though, that we found is that even in the patients who had no history of hip dislocation, we still found a higher percentage of patients in that group who ended up having intra-articular air in the unstable hips. So conclusions here, a positive EUA is more likely with the presence of intra-articular air on CT, and this is regardless of a history of dislocation or fracture size. We also found fracture displacement greater than 5 millimeters and a sagittal angle greater than 70 degrees also predicts a positive EUA. So when you see these characteristics present on your injury radiographs, you should be more inclined to consider an EUA to rule out instability. And then key takeaways here. Again, intra-articular air on CT, it may indicate occult instability, and this is especially helpful when fracture size is borderline. We know, again, that posterior wall fracture size and the history of dislocation alone cannot be independently relied upon for your management. An important thing is that intra-articular air on CT scan and evaluating it, it's very simple to evaluate. You can teach it to any resident, so it takes very little time, especially for the busy residents down in the ED seeing multiple consults. Easy to come up with a plan in the morning for your attendings. Then intra-articular air on CT scan does not mean that the hip, of course, is definitely unstable, but it just adds another variable for your decision making between EUA and no EUA, and then ultimately leads you down to a path of possible fixation or not. That's it. Thank you.
All right, if the presenters wouldn't mind coming up, we'll have a few questions for them.
I have a question for Dr. Flores. Displacement, preoperative displacement of the fracture and status of the meniscus all probably have a huge impact. So there's some selection bias from your distribution of. So how do you account for preoperative displacement? Did you analyze that?
That was not analyzed in our study. It was just based off of treatment from the retrospective. So whether they underwent operative intervention.
Yeah, you should probably do that and also look at quality of reduction. You know, if you get an anatomic versus ones you can't reconstruct because they're so dusted.
Yes, sir.
Alignment, all those things could, before you analyze whether there's a difference, you got to look at a lot of other factors.
Yes, sir.
Dr. Flores, what was, how did you guys decide who to treat non-operatively? Because that would also be a very big part of the selection bias.
For sure. That was, at least from the retrospective aspect, multiple patients were called. These were the ones that have essentially answered. We used a propensity match. So their initial evaluations were decided based on the operating surgeon at that point, whether they underwent operative intervention. I'm assuming they used displacement, whether the fracture was stable, unstable.
Sorry, one more question, Dr. Flores. So you get a tibial plateau fracture in the ER, high energy displaced. Do you recommend that they have surgery or not?
High energy and displaced,
Mm-hmm.
yes, sir. Depending on obviously fracture pattern, displacement, what their skin is doing at that point in time would be, a candidate for potentially external fixation, but high energy and displaced, in my opinion, would be an operative.
Yeah, and I agree with you. It's just, you just have to kind of temper your recommendations in a study, just because, you don't want people reading it and say, okay, we're treating tibial plateau fractures on off now.
For
So
sure.
just,
Yes, sir.
temper the results. But thank you. It was a good study. Dr. Kucharek, I have a question as well. What did you consider a proximal humerus fracture?
Well,
Because
so
that's pretty broad.
right, yeah. So basically, it was like in terms of like extension, like distally, or.
I mean, how did you classify it? What is a proximal humerus fracture in your study?
So it had to be coded based on the CBT code for, which I don't remember off the top of my head, but
Okay.
For OREF or arthroplasty for proximal humerus fracture, we basically pulled the patients based on the ICD-10 code
Mhm.
and then matched it with the CPT code. And because Dr. X may have been operating at a hospital 40 minutes away that we didn't have EMR access for, so we didn't have those preoperative radiographs. We had to go based on the coding, so we couldn't necessarily see what it was beforehand. I mean, you could, I guess, go through the radiographs in the office 6 weeks later and try to guess, but we didn't have any preoperative radiographs to stratify it. So it was based on coding.
Yeah, so like a proximal shaft was probably excluded then.
Yeah,
okay.
I think it's a different code.
And another question is you had 459 patients in 3 years that got some type of surgery for a proximal humerus fracture?
Mm-hmm. Well, it wasn't just those two mentors that were on the paper. Sure. It was the entire Florida Orthopedic Institute. So I think in that period of time, there's probably 50 orthopedic surgeons taking call at various hospitals in the Tampa Bay area. So I think that's why the numbers were so high.
Okay, yeah, that would have been good to know because that's a lot of proximal humerus surgery.
Yeah.
Question for Jacob. Did you, when you're looking at the air, did you find any difference in tiny little bubble versus a ton of air? So does the amount of air in the joint correlate with a positive EUA? And then also, how did you define a positive EUA? Because I could dislocate your hip under anesthesia, no problem, right? Yeah. So how hard do you twist? What's positive? You know what I mean?
Yeah. For your first question, no, we did not stratify based on the amount of air, just presence of air or no air. And yeah, that was one limitation of our study is the difference. There was multiple surgeons who are performing the EUA. Everyone does it differently. Some apply traction, some don't. So it was just up to the operating surgeon how they performed it.
Dr. Page, you said yourself in one of the limitations, it was kind of a modest sample size for patients in comparison. Did you do a retrospective or post hoc power analysis to make sure that you were adequately powered for the study to compare the two on union rates?
We did not do a power analysis on the retrospective review. We're just kind of based off of when the Smith+Nephew implant that we were using for the periprosthetic plating system became available. And the amount of time that we used that plate, we kind of retrospectively reviewed the patients that were treated with just a plate alone to match the time period, but there was no power analysis.
Thanks, guys.
We'll move on. We have Dr. Rector talking about primary total hip arthroplasty via the direct anterior approach for displaced femoral neck fractures in non-geriatric patients. Oh, sorry. Don't want to take everybody's break. We'll take a break. Sorry. Just eager to keep going. All right, we'll take a break. Thank you.
Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself, so it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself, so it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
you have to see things before you can do them yourself. So it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself. So it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself. So it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today.
Yeah, for like 1-2 hours.
Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions.
I'm literally flying to Nashville.
Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself, so it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today.
Find any space. $50 on it so far. My goal was to put a mega on it this year. Yeah, and then leave it. Get it again. Doing absolutely nothing. He's not selling it. So half the flow there. That's not even flow. All right, let me get versus because the owner. Gives you notice in the airport. So we're going to see them out. All right. Right. Yeah. And you get lithium and bring it back to the street. And he's going to, I mean, he can space tourism. All you can hear Tokyo. That's pretty badass to get right off the rock and go to Tokyo for dinner.
All righty. Okay. We'll go ahead and get started. Now I'd like to welcome Dr. Rector to talk to us about primary total hips and fractures.
All right, I'm Griffin Rector. My presentation is primary total hip arthroplasty via the direct anterior approach for displaced femoral neck fractures in non-geriatric patients. So ultimately, this is a clinical conundrum. We know these patients historically don't really do very well with OREF. In this landmark study of 492 patients across 26 centers, there was a 45% major treatment failure rate. In another really large study of 796 patients, we saw that 1 in 3 of them required reoperation and 1 in 7 of them got converted to total hip arthroplasty. So again, the complication rate of OREF is really high in this group. And what we do know is that outcomes for total hip arthroplasty for displaced femoral neck fractures in the geriatric population is pretty well documented and they do fairly well. But it's virtually non-existent in the younger patients. And again, there's no prior data on the direct anterior approach in young femoral neck fracture patients. Ultimately, there is some concern about implant longevity in this younger active population though. So why consider total hip arthroplasty for these patients? One, conversion total hip arthroplasty after failed OREF does have inferior patient-reported outcomes. We do know that modern implants do a lot better than they used to. And faster return to full weight bearing and return to the workforce is a very important consideration in this younger population. So the purpose of this study, again, was to look at outcomes, total hips after displaced femoral neck fractures using the direct anterior approach. Everyone was less than 60 years of age. And this was ultimately a single center series, retrospective from a level 1 trauma center, required a minimum of 1 year follow-up, again, total hip arthroplasty, and our primary outcome was all-cause revision surgery. All the patients were also contacted in a prospective arm of the study, a minimum of 3 times to get a patient-reported outcome. 41% of patients participated or responded, and all patients with a known revision surgery were excluded from this. So overall, 49 patients were included. The mean age was 50. The mean follow-up was a little bit north of 2 years. There were no significant medical comorbidities, 18% type 2 diabetics, 80% of them were ASA 1 or 2, and 31% of them were smokers. These were all high energy injuries, as we would expect with this younger femoral neck fracture pattern. 6 of them were polytraumatized, and the majority of them had this Powell's type 3 vertical shear femoral neck fracture. All received a press fit femoral stem. They were collared 86% of the time. The mean operative time is about 89 minutes. And ultimately, what we found was 92% of patients remained revision-free of surgery at around 2 years. In terms of functional outcomes, 78% of them were discharged at home, 12% to rehab. When you think about your geriatric population, this is obviously a much different cohort. 94% of them returned to pre-injury ambulatory status, and then the average Harris hip score was 90, which correlates to an excellent score, which is better than OREF in the literature. Looking at the patients that did have some major failure, 4 patients underwent revision at a mean of 2.5 years, and 3 of them were for femoral stem aseptic loosening. 1 was for symptomatic HO, 1 had superficial infection, but there were no deep infections, PJIs, dislocations. And when you were looking at failures by stem design, what we did find that there was 1 specific subgroup that had a really high failure rate, and this has been demonstrated in the literature that this group has a high rate of aseptic loosening that's been deemed unacceptable. And when we did a Kaplan-Meier survivorship analysis, there was a 97% survivorship at 1 year. And ultimately, our late follow-up was limited beyond a year and a half because of the disproportionate number of revision rates that were happening in this exact tech group. So again, after the sensitivity analysis, 98% implant survival at a mean 2-year follow-up. And ultimately, only 1 reoperation was observed after the sensitivity analysis, which demonstrates that the survivorship failures were more likely driven by implant-related variables rather than surgical approach or for indication performing the total hip arthroplasty. We also found favorable early to midterm outcomes in these non-geriatric femoral neck fracture patients with low rates of revision surgery and low rates of overall complications. We found a high rate of return to pre-injury ambulatory status and superior functional outcomes compared to the OREF literature at 2 years. But ultimately, you have to weigh the benefits of this procedure in light of some of the limitations, namely those being implant longevity in a younger population, PJI, periprosthetic fracture, and dislocation, which are all concerns. We do also know the direct anterior approach has a known favorable association with early recovery, and this might be more favorable for young femoral neck fracture patients. Total hip arthroplasty has also been proven to be a more cost-effective treatment option for displaced femoral neck fractures in middle-aged patients, and with increasing age being more favorable. But ultimately, discussion is warranted with your patient regarding the optimal treatment outcome, whether that be OREF or total hip arthroplasty. So take home here is that total hip arthroplasty via the direct anterior approach may be a reasonable index treatment option for displaced femoral neck fractures in patients under 60 years of age. Thank you.
Next up, we have Dr. Bailey from USF talking to us about femoral distalization using rebar screw augmentation in primary total knee arthroplasty.
Morning, everybody. I'm Dan Bailey. I'll be coming from University of South Florida, FOI, talking about this femoral distalization using the screw augmentation. So why is this important? Achieving a balanced flexion extension gap is one of the fundamental goals of primary total knee arthroplasty. When the extension gap is larger than the flexion gap, patients are at risk for recurvatum instability, poor postoperative function, and ultimately difficult intraoperative decision-making. Distal femoral augmentation with rebar screws provides an alternative method to restore the extension balance. The purpose of our study was to evaluate the clinical outcomes of this technique in a large consecutive series of primary total knee arthroplasty. You see the images on the right demonstrate our rebar screw-assisted femoral distalization technique. If the knee is hyperextending during trialing, the distal femoral augment is needed due to the loose extension gap. First, a chamfer cut is placed onto the distal femur and the trowel is placed over this. The chamfer cut is then modified until the extension gap is appropriate. The cut is then measured with a caliper to determine the height of the screws. Holes are then drilled for four 6.5 millimeter cancellous screws, just medial to the lug drill holes. Screws are then placed into the distal femur tact as reinforcement framework and measured to match the desired height for the chamfer cut. Bone cement is then applied around the screws, creating a reinforced cement mantle. The femoral component is implanted on the augmented surface, effectively distalizing the femoral component to adjust the extension gap as needed. So we performed a retrospective review of 180 primary total knee arthroplasties between 2011 and 2026 using 6.5 millimeter rebar screws for femoral distalization. Our primary outcomes were active flexion and extension measured at 6 weeks and 1 year. Secondary outcomes included ambulatory status, complications, and revision surgery. The average patient was 65 years old, just over half were female. The mean BMI was approximately 31.5 and nearly 2/3 were ASA class 3. In regard to the clinical outcomes, our range of motion recovered well following surgery. Active flexion increased from 116.6 degrees preoperatively to 119 at 1 year, slightly exceeding the preoperative values. Our extension deficit improved from 1.7 degrees pre-op to only 0.4 degrees at 1 year, indicating restoration of near full extension. Our functional recovery paralleled these findings. The proportion of patients requiring a cane or walker decreased from 42% at 6 weeks to just over 14% at 1 year. And complications were overall uncommon. They reflected a mean follow-up of approximately 1.5 years. Mechanical failure occurred in 1 patient, aseptic loosening and periprosthetic infection each occurred in 3 patients. Fracture occurred in 4 patients. There were no DVTs or PEs, and 8 patients underwent all-cause revision from the cohort. In conclusion, rebar screw-assisted femoral distalization reliably restored extension while preserving post-op range of motion. This technique represents a reproducible option for managing the extension gap laxity in appropriately selected primary total knee arthroplasty patients. Additional studies with comparative cohorts and longer follow-up will help further define its role in surgery. Thank you.
Next up, we have Dr. Graham from Atrium, Carolinas Medical Center, talking to us about can chronic antibiotic suppression after 2-stage exchange arthroplasty prevent treatment failure?
All right, good morning, everybody. My name is Dylan Graham. I'm from Carolinas Medical Center in Charlotte, North Carolina. Happy to be here today. This is a great conference so far, so thanks for having us. Great mentors in Charlotte, Dr. Faring, as mentioned, Dr. Otero, and the crew. I know that you were there as well, Dr. Green. So a great experience with PJI. We have a high-volume PJI center, so we're fortunate enough to be able to perform some research on this topic. So just some background. This is periprosthetic joint infection complicates about 1% of primary hip and knee arthroplasty and is a devastating complication, as we know. 2-stage exchange is our gold standard, but 5-year prosthetic survival after reimplantation can be as low as 38%. And a repeat 2-stage after failure succeeds only 22 to 50% of the time. In 2017, as seen here, Frank et al. Conducted a level 1 RCT, which showed just 3 months of antibiotic suppression, cut failure from 19 to 5%. So we've been thinking about chronic oral antibiotic suppression for quite some time, but we're still not quite sure what the optimum duration is. So that's what we're seeking to find out here. This was a single center retrospective cohort study, including patients from 2010 to 2020 with chronic PJI treated with 2-stage exchange arthroplasty, 534 procedures, and 512 patients with an oral susceptible organism with at least 12 months of follow-up. Everyone received a planned 6 months of oral suppression, and continuing beyond that at surgeon's discretion, define chronic suppression, about 15% of our cohort. Groups were well matched at baseline, apart from more alcoholism in the suppression group. Primary outcome was treatment failure, which included reinfection, reoperation, or active infection at final follow-up. And here are our results. Of 446 procedures without chronic suppression, 88 failed, which was 19.7%. And of 88 procedures on chronic suppression, 0 failed in this cohort. So every suppressed patient remained infection-free at a median of 2.3 years of follow-up with a significant p-value. And here's our Kaplan-Meier survival curve for infection-free survival, which shows that the chronic suppression group stays flat at 100% infection-free survival, while the no suppression group shows a steady attrition, which falls to about 60% by long-term follow-up, consistent with
several other studies in the literature. So for how long and what is the optimal duration for these patients, at least in our cohort? Patients who stayed suppressed without failing had taken antibiotics for a median of 13 months versus 7.2 months in the failure group. We performed a threshold modeling analysis, which found significance at 24 months, but not at 18 months. So together, this points to a minimum suppression of about 2 years for these patients. Even after adjusting for host grade, vascular status, culture status, suppression remained the dominant protective factor in this group. Biologically, it likely limits biofilm formation over time, suppresses residual low-grade infection, and guards against hematogenous seeding for these at-risk patients. But of course, we have to weigh this against the real risks of chronic antibiotic use, such as hepato and nephrotoxicity, C. difficile infection, resistance, black box warnings and risks with the use of fluoroquinolones and years of adherence burden. This is a retrospective single center with a 0 event suppression group. So this is a limitation of our study, but I think it's an interesting finding and worth discussing. And of course, we need to discuss this in collaboration with our infectious disease doctors, as they often help us make these decisions for our patients. So in conclusion, chronic oral suppression after 2-stage arthroplasty was associated with a dramatic reduction in failure in this group, 0 versus about 20%. And 100% infection-free survival at a median of 2.3 years. Data supporting suppression at least 24 months in appropriate candidates, balancing against the risk, of course. This is level 3 evidence of prospective trials of optimal duration are the logical next step for this group of patients. Thank you, and happy to take questions at the end. Next up, we have Dr. Jack Hardman talking about use of constrained liners in all-cause revision hip arthroplasty to revise or retain the cup.
Good morning. As Dr. Shaw said, my name is Jack Hardman, one of the 4th years here at Orlando Health. I'm going to be talking about constrained liners in revision arthroplasty. So the purpose of this study was to compare outcomes of constrained liner placement with cup revision versus cup retention in revision arthroplasty and assess the effect of acetabular repositioning on instability and failure. So why this matters, instability is one of the leading causes of revision in total hip arthroplasty, and constrained liners is a critical tool that you can use for managing recurrent dislocations, whether it's for abductor deficiency, compromised soft tissue envelopes, or other neuromuscular issues. So there's continued debate on when you're doing these revisions, whether to retain or revise the acetabular cup or displace in a constrained liner. This was a retrospective cohort study, single volume tertiary center. We looked at revisions with constrained liner placement from January 2010 to December 2023 with a minimum 1-year follow-up, and resulted with 115 patients. Our primary analysis was based on 2 groups, one having the cup revised and the other one having the cup retained, and a secondary subgroup analysis looking at acetabular repositioning, which was a cup revision or a phase change versus just a modular constrained liner exchange. And the primary outcome was subsequent dislocation or revision surgery. So a phase change, as kind of described by Dr. Heidekavich previously, was a method to change functional version and inclination of the hip while retaining the cup. So in a well-fixed acetabular cup, you can use cement to place this constrained liner in a position for impingement-free range of motion. And you can see that, an intraoperative photo there of that. For our results, we did not have any difference in patient demographics, but we did find that those who had a history of instability had higher rates of their cup being retained, and then those with a revised cup had higher rates of history of infection. For surgical factors, there was no difference in approach, vendor, head material, or head size. The retained cup group did have higher instability as indication for surgery, cup inclination, and then immediate post-op weight bearing. Those who did have the cup revised had higher infection as indication for surgery, as well as Prosky cup classification and femoral component revision as well. For our outcomes, we found that those who had a retained cup did have higher subsequent dislocations and subsequent surgery, but there is no difference in all other post-op complications. For comparing reasons for revision, we found that those who were revised due to instability were more likely to have subsequent dislocations. And then our other subgroup analysis looking at acetabular repositioning, we found it trended towards significance of using this phase change using acetabular repositioning versus not changing that at all. So overall, we kind of found that constraint alone is not enough. So retention of the acetabular cup was associated with significantly higher rates of subsequent dislocation and failure compared to acetabular cup revision with a 2.4 higher dislocation rate. And then acetabular repositioning with either full cup revision or phase change trended towards those improved outcomes. So again, patients revised for instability also had higher subsequent dislocation rates regardless of strategy, kind of underscoring the difficulty managing this population. So these findings suggest that constraint alone without addressing component malpositioning might be insufficient, and we should consider acetabular revision or phase change when it's feasible for these patients. So again, overall, surgeons should really critically evaluate the cup position and impingement-free range of motion when they're placing these constraint liners. So some limitations, again, retrospective study, selection bias based on cup revision decisions. You're obviously not going to leave everything in there if you're revising for a infection, but if you're revising for instability, it's more of a surgeon preference. Single center study, and then there's heterogeneous revision indications between these groups as well. Future directions could do prospective RCTs, and then analysis of specific cup position thresholds that predict constrained liner failure, as well as longer-term follow-up to assess the durability of these repositioning strategies. Thank you.
Presenters would like to come up for some questions.
Dr. Bailey. So when you looked at yours, did you look at the location where these surgeries were done? Were these more at the hospital setting, the ASC? Like anytime we're usually using what we call a Medicare augment, which is a screw and cement as opposed to a metal augment. It's usually for cost more than anything else. Are you guys doing this for cost purposes or just for balancing?
It was just for balancing. It was all done at a hospital setting.
Did you, it was a slightly higher increased risk of PGI as well, 2.7, I believe, compared to the national average. Are these cases longer usually when they're doing that?
Yeah, not significantly longer, to be honest with you. It does add a few extra minutes because you have to adjust the chamfer cut, just to effectively balance that extension gap. So I would say a few extra minutes, but nothing significantly longer.
Question for Dr. Graham. Every now and then you do a replant, two-stage, and your cultures are positive at the time of replant. Did you include or exclude those in your analysis?
So we had both culture positive and culture negative patients in this cohort, not included in this presentation just for brevity, but those were included in the analysis.
Did the ones with positive cultures have a higher rate of failure than those that had negative cultures at replant?
No, sir. There was no difference, at least statistically, between the two groups with culture positivity versus negativity in the chronic or short course groups.
Cool, thanks. Question for Griffin. Last we spoke, I've seen some of your data before. You were going to add a comparison group because we did fix a lot of these into 30 to 60-year-olds, and over time we're migrating to replacing. Do you have any information on what was the survivorship of the OREF in our hands?
We don't have the survivorship data yet. That's in the middle of being analyzed right now. We have a cohort of about 130 to 140 total patients to compare, pretty equal between the two, with a prospective arm about 50% follow-up. So we should be able to have a pretty good survivorship analysis.
Okay, and you're going to look at fracture pattern, just age, all that, just to make sure that it's not highly selected for the most dusted fractures, right?
Yes, sir.
Question for Dr. Graham. Was there any difference between the type of antibiotics between your guys' two groups? Because there are definitely some oral antibiotics that have better bioavailability and things like that. And was that at the discretion of ID or the surgeon?
It's a little bit of both. I think we have a great relationship with ID in Charlotte, so it's pretty seamless communication, at least between the two. Rifampin is commonly used, other antibiotics targeted, if they're culture positive, targeted towards that, but there was no difference in the actual antibiotic used in one group versus the other. I do think that's very important, as well as the actual organism between the groups. And so we have all that. There doesn't seem to be a difference between the two groups. I think just talking to some of our faculty, it's some patients who go on to needing a 2-stage revision orthoplasty for PJI, they just keep them on antibiotics indefinitely, like lifelong suppression, just because level 5 evidence has shown that it keeps them away from an infection. So I think a lot of it is surgeon discretion, and ID is obviously very helpful in kind of guiding us with that.
Yeah, to follow up on his question, how do you define failure? So if they come back, they're suppressed, they say, "Doc, I had my knee 5 years ago, it hurts." Are you aspirating those people, or are you only considering a failure as a reoperation for infection?
So at least in this study, the infection group included reoperation for infection or infection at final follow-up. So if we knew that they had infection, they just haven't gone on to requiring another reoperation or have gotten another reoperation, they were counted as an infected patient.
Diagnosed infection.
Yes, sir.
Question for Jack. Did you see a difference in outcome if you revised the femur, where you can optimize offset and leg length and minimize impingement with modular stems? Did you look at that to see whether concomitant femoral revision increased your success rate of using a constraint liner?
No, we did not yet, but that's a good.
You may want to
future
look at
direction.
that too.
Yeah.
Going back to Dr. Graham. So, I mean, a lot of the pushback that we get here is from infectious disease. And I remember Charlotte has a great reputation with their infectious disease doctors. Have they seen any resistance in bacteria there? Like, have they said anything? That's a big knock. Like, if we try to bring that and go for 2 years of suppression here in Orlando, what are we going to tell our infectious disease doctors?
I think it's a great point. And I think it definitely depends on where you are and just the relationships that you have with infectious disease. Like you said, I think we're very fortunate in that they're able to kind of comply with our recommendations as far as keeping patients on antibiotics. There's obviously a concern about resistance long-term, and they kind of push that on us, but I think it's just a risk-benefit conversation depending on the patient's health status, and every other factor that kind of goes into that conversation. So it can be a battle sometimes for sure, but I think it's definitely important to think about. So.
And if anybody in the audience has a question, feel free to pass the mic back.
Move on. Dr. Druskovich will talk to us about table versus stretcher, a prospective randomized trial.
Hello, I'm Kate. I'm one of the 5th years here at Orlando Health. A little bit of background. As we all know, OR efficiency is critical for safe, cost-effective surgical care. And making small changes to the workflow can improve efficiency, but we have to first maintain patient safety as our top priority. So in a specialty like hand surgery, where we are doing a high volume of cases, often shorter duration cases, making a small change to our workflow can have a large cumulative impact on our OR days. The current standard OR workflow is bringing the patient into the OR on the stretcher, transferring them over to the OR table, doing the surgery, and then transferring them back to the stretcher at the conclusion of the case. Some concerns with this is it does involve a lot of staff lifting, and 1/3 of all hospital worker musculoskeletal injuries occur during these patient transfers. And then there's also a risk to the patients. There can be falls, there can be positioning risks, and this accounts for about 1% of all perioperative safety reports. So some advantages of stretcher-based surgery, meaning keeping the patient on the stretcher for the case. There are less patient transfers, so this improves safety. Previous research has shown that it saves 4 to 7.5 minutes per case, so that can be more cost-effective. And it's been safely used in other specialties, including ophthalmology and GI for years. Concerns that people bring up with stretcher-based surgery are, will the sterility be compromised? Will surgical access be limited? And will there be an increase in complications? So the purpose of our study was to determine whether hand and upper extremity procedures performed on hospital stretchers are as safe as those performed on standard OR tables. Our hypothesis was that stretcher-based surgery will demonstrate no increase in complication rates compared to standard OR table positioning. Our study design, this was a prospective randomized controlled trial from 2017 to 2021. Cases were done at both a level 1 trauma center and our associated outpatient surgery center, and included trauma and elective cases. Our participants were adults over 18. We did exclude patients with pre-existing spine pathology or chronic neck and back pain because they were being routinely kept on the stretcher for surgeries when possible. And we included patients with a minimum of 6 months of follow-up. So our patients were randomly assigned into 2 groups. We had the stretcher group where they were kept on the stretcher, and we used the arm board that kind of slides under the table and has a kickstand to do the surgery. And then the other group was the OR table group where they were on either a Birchfield or a Jackson, and we had the arm attachment on the table. Outcomes we looked at were 6-month post-op complication rates, including infection, wound issues, neurovascular injuries, any returns to the OR, and any other adverse events. So here are results. The main things to note, there were no significant differences in demographics between the 2 groups. And then there were no statistically significant differences in complication rates between the 2 groups. Our complication rate in the stretcher group was 3.7%, and in the OR table group was 2%. So looking at what our complications were, there were only 3 total complications. In the stretcher group, there were 2 post-op complications. One was a superficial infection that resolved with antibiotics. One was a deep infection that did need a repeat IND in the OR, and then the wound healed. But it's important to note the one deep infection was in a trauma patient with a blast injury to the hand, so they were already at an increased risk. And then the OR table group, we just had the one superficial infection that resolved with antibiotics. Some strengths of the study, we did include a broad spectrum of cases, including elective and trauma cases, and they were performed in both inpatient and outpatient settings, so it's very generalizable. And we specifically evaluated for the complication rate, so this does give some higher evidence that stretcher-based surgery does not increase the perioperative risk. Some limitations of our study, all these cases were performed by 1 surgeon. And then although our study was adequately powered based on our pre-study calculations, the overall complication rate was low, so this did limit our ability to detect differences between the groups. So this study does show that there was no increase in complication of stretcher-based surgery, and prior research has shown that stretcher-based surgery may improve our OR efficiency and reduce costs. So taking those 2 things together, we concluded that performing hand and upper extremity surgery on a hospital stretcher is a safe alternative to traditional OR table positioning, with the secondary benefit of improving efficiency and being more cost-effective. That is all. Thank you.
Next up, we have Dr. Devara Sethi talking to us about, does 10 minutes of intraoperative nerve stimulation improve outcomes following nerve transfer?
Good morning, everyone. I'm Manohar. I'm one of the PGY3s from Atrium Health, Carolinas Medical Center, North of Carolina. Today, I'll be talking about whether 10 minutes of intraoperative nerve stimulation improves outcomes following nerve transfer. So briefly, brachial plexus and peripheral nerve injuries can be very challenging injuries to treat. This is because of a multitude of reasons, one being peripheral nerves regenerate slowly at a rate of 1 millimeter per day. And additionally, when they attempt to recover, they often lack direction. These 2 factors combined result in a prolonged denervation, which can result in irreversible muscular fibrosis. Nerve transfers address some of these problems by converting proximal lesions into distal lesions, which allows for faster and more effective reinnervation. However, in an effort to more comprehensively address these problems, brief intraoperative electrical stimulation is one emerging technique that has been described in several basic science and animal studies initially to preferentially target and accelerate motor axonal regeneration and lead to more organized axonal sprouting as well at a cellular level. Additionally, clinical studies recently have also demonstrated that electrical stimulation enhanced outcomes following both carpal and cubital tunnel release, but their potential role in outcomes following nerve transfers has not been studied. So the purpose of our study was to compare clinical outcomes of upper extremity motor nerve transfers that received brief 10-minute intraoperative electrical stimulation with those that did not. So this was a retrospective cohort study including radial to axillary to recover shoulder abduction and median or ulnar to musculocutaneous nerve transfers for elbow flexion from our institution between 2015 to 2025. Patients under the age of 18 or folks that lacked at least a year of follow-up or lacked an MRC grade documented in the chart were excluded. The primary outcome in our study was the maximum post-op MRC grade that was achieved, and our secondary outcome included the time to recovery in addition to any complications. So with regards to technique, all nerve transfers took place under general anesthesia using standard microsurgical technique for the stimulation group. After standard coaptation was performed, we completed 10 minutes of continuous stimulation applied proximal to our coaptation site using a checkpoint nerve stimulator set to 2 milliamps and 100 microsecond pulses. So with regards to our two cohorts, we had 58 patients in the no electrical stimulation and 25 patients in the electrical stimulation cohort. There were no differences between these two cohorts with regard to patient, injury, or surgical characteristics. With regard to our primary outcome, we noted that stimulated patients demonstrated better recovery, with at least 88% reaching M4 or M5 grade versus only 58.6% in the non-stimulated group. This was a significant finding with a p-value of 0.03. With regards to our secondary outcomes, the stimulated group was also noted to have a shorter time to maximal documented recovery at 10.1 months versus 14.3 months in the non-stimulated group. This was also a significant finding with a p-value of 0.03. With regards to complications, we did not encounter any wound issues in either cohort, but we did note 4 cases each of donor sensory dysfunction in both cohorts. We also did perform a regression analysis as well, which confirmed that therapeutic stimulation was an independent predictor, and stimulated patients being 6 times more likely to achieve an MRC grade of M4 or M5. And other significant predictors included age, smoking, and mechanism of injury. So the major takeaways from our study are that electrical stimulation increased the proportion of patients achieving M4 or M5 grade, and it also decreased the time it took to achieve this. Additionally, when controlling for covariates, stimulated patients were 6 times more likely to achieve M4 or M5 grade. And then finally, this is a readily implantable technique and adds only about 10 minutes of operative time. Our conclusion was that this is a promising adjunct in peripheral nerve reconstruction, and our practice has actually shifted so that every single nerve transfer that we have now, we are using electrical stimulation for 10 minutes. Here are my references, and thank you.
Next up, we have Dr. Araujo talking to us about increasing complication rates after complex wrist reconstruction and American Board of Orthopedic Surgery database study.
Good morning, everyone. My name is Olivia DiRuggio. I'm a PGY3 at the University of Miami-Jackson, and an honor to present to you our study today. We would like to acknowledge the ABOS as part of the study, whose de-identified Part 2 oral case database was created by CPT code to gather data for our project, and they have provided approval for presentation of this project today. So distal radius fractures are currently the most common fracture pattern in adults, and it is expected that this number will continue to rise as our population ages. Volar plate locking plate fixation came to be in the early 2000s with Dr. George Orbe, and has improved our ability to not only restore radiographic parameters, but to improve patient outcomes. VLPs have now largely replaced prior treatment methods such as external fixation, K-wires, and casting, where malunion and post-traumatic arthritis rates were up to 50% in some studies. So VLP technology, as you can see in the image on the bottom left, has continued to evolve, where it's now the gold standard for treatment of distal radius fractures. However, salvage wrist reconstruction procedures, such as complex osteotomies and wrist arthrodesis or arthroplasty, are now less often being required. We hypothesized that because of this, complications of these more rare procedures may be higher. So we collected data from the ABOS Part 2 case list database to identify case numbers and complications of post-traumatic wrist reconstructions, including osteotomy, osteoplasty, arthrodesis, and arthroplasty before and after the advent of volar locking plates in the early 2000s. An early and late cohort were divided and statistics were performed, with a p-value of less than 0.05 being significant. 1,529 cases were included in our study, with 968 patients being in the early cohort, which was from 1998 to 2000, and then 561 patients in the late cohort, 2020 to 2022. So we'll look in the next few slides, but I'll just kind of cover our results. Overall, there was a decrease in the pure number of wrist reconstruction procedures performed in the late cohort versus the early cohort by approximately 40%. And as you'll see in the next few slides, Surgical complication rates after wrist reconstruction surgery were higher in the late cohort than in the early cohort, about 25% compared to 12.2%. Wrist arthrodesis, osteoplasty, and osteotomy procedures had higher overall complication rates in the late cohort, and this same group had higher rates of postoperative stiffness or arthrofibrosis. There's a lot of information here, but just summarizing the bold, there was a higher prevalence of tendon, ligament, or bone injury in patients who underwent wrist arthrodesis in that later cohort, 3.44% versus 0.5%. And there was a higher incidence of pain in patients who underwent osteoplasty or arthroplasty also in that later cohort. There are some limitations to this study, of course. It is a non-comprehensive case list, and we know that coding processes for distal radius fixation in the late 90s compared to the past 20 years have likely changed. There's also heterogeneity in training prior to a resident entering the upper extremity fellowship. And these complications listed are self-reported. They may not be fully comprehensive. In addition, these complications are data points as opposed to specific cases that may be better characterized in future research. In conclusion, volar plating for distal radius fractures has resulted in improved outcomes and decreased rates of post-traumatic wrist arthritis and malunion. Complication rates have continued to increase, and salvage procedures are being performed less often, which may be in part due to fellows having less exposure to these cases and also having heterogeneity between upper extremity fellowship training. So we do suggest that complex wrist reconstructions be performed by fellowship-trained upper extremity specialists, and that in light of this data, fellowship directors may even consider augmenting the training that fellows are receiving with cadaver labs or even virtual reality augmented training so that fellows are ready to perform these procedures when they are indicated. Ultimately, having the goal that fellows have adequate exposure to the procedures during training so that as the landscape of distal radius fracture management changes, surgeons are able to perform any indicated procedure well and provide excellent outcomes for patients. Thank you very much.
Next up, we have Brennan Costco, timing of tourniquet release, a prospective randomized trial.
Good morning, everyone. Thank you for being here. Thank you to OREF for hosting, and thank you to the panel for your support. Looks like we got cut off here, but today I'm talking about timing of tourniquet release and upper extremity surgery. It's a prospective randomized trial. So tourniquet use is standard in upper extremity and other surgeries. It provides improved visualization, reduced blood loss, and efficiency in the OR, but little evidence exists on the difference in outcomes between tourniquet release before versus after wound closure, especially in the upper extremity. There's a lot of data out there from the total knee arthroplasty literature, but nothing really on upper extremity. And it's largely based on surgeon preference. There's an old survey study of surgeons in the ASSH, specifically for carpal tunnel, and 51% said they closed before wound closure. 49% said they close after, or they drop the tourniquet after wound closure. So it's definitely up to surgeon discretion as far as we know. So the purpose of this study was to determine the difference in short-term outcomes after releasing the tourniquet before versus after wound closure. And we hypothesized that there would be no difference. It was a prospective blinded randomized clinical trial of adult patients undergoing a variety of orthopedic upper extremity surgeries at a level 1 trauma center. They were randomly allocated to tourniquet release prior to or after wound closure. And intraoperative parameters included the specific procedure, length of incision, the location, total tourniquet time, use of electrocautery for hemostasis, closure, completion time, and intraoperative complications. And the short-term follow-up parameters were VAS pain scores, patient satisfaction, quick dash scores, and any complications requiring intervention. The demographics were not different between groups. There were 214 total enrolled patients, 172 completed protocol follow-up, 107 patients per treatment arm. There were 150 elective and 64 trauma cases. And like I said, demographics were similar. There was no bias towards specific procedures in this group. And these were, this was the general spread of procedures. We have carpal tunnel, endoscopic open, cubital tunnel, trigger finger, OREF, of hand and finger fractures specifically. We did not include both bone forearm fractures. We did include distal radius fractures, mass excisions, INDs, CMC arthroplasty, tendon repairs. So the intraoperative results, there were no complications that required intervention. 16% of the patients that had the tourniquet released prior to wound closure required electrocautery for hemostasis. There was no excessive bleeding noted, even when the tourniquet was dropped after closure. And there were no significant differences in tourniquet, surgical time, or incision length. So at the short-term 2-week follow-up, there was no difference in quick-VAS pain scores or in patient satisfaction. There were no postoperative hematomas that required intervention, and findings were made similar when we substratified between the trauma and elective groups. So as hypothesized, there was not a significant impact whether the tourniquet was dropped before or after wound closure, and releasing after closure should improve visualization and closure efficiency. However, that was not borne out in this cohort, and clinical outcomes in the short term were comparable. So this study is not without limitations. We included a wide variety of procedures, but we're not powered enough to substratify between specific procedures. So that's a limitation that could be looked at going forward. It was a relatively small sample size to detect rare complications. Potentially the surgeons could be biased once they know which group they were randomized to, including if they tried to close faster to artificially change the closure time or some other parameter of the intraoperative data collection. Obviously, very short-term follow-up at 2 weeks, so we would need to look at much longer follow-up to see if there's any effect, and wall-on procedures were excluded. So in conclusion, I think, as it has been for many years, this is up to surgeon discretion. Obviously, there may be some differences for specific procedures, but we weren't powered enough to examine that in this study. But in the short term, at least, there were no meaningful differences in pain function, satisfaction, or complications. And this supports flexibility in an upper extremity surgeon surgical practice. Thank you.
Next up, we have Dr. Vaccaro, Functional Outcomes and Reoperation Rate of Nanoscope-Assisted Carpal Tunnel Release, a Retrospective Analysis.
Hi, my name is Dr. Vaccaro. I'm a resident at Rothman Orthopedics, Florida at Advent Health, and I'm presenting on functional outcomes and reoperation rate of nanoscope-assisted carpal tunnel release, a retrospective analysis. Backwards. A little bit of background. Carpal tunnel syndrome is the most common compressive neuropathy. It was historically managed with an open incision to reduce postoperative morbidity, including scar tenderness, facilitate early return to work, and minimize soft tissue trauma. It has evolved from a traditional open technique toward increasingly less invasive approaches, such as endoscopic carpal tunnel release. A lot of studies have been performed comparing the two. They have shown to have similar 12-week outcomes, similar complication rates. There's less pain and faster recovery with endoscopic carpal tunnel release. And recent developments in needle arthroscopy have expanded the role of minimally invasive visualization in upper extremity surgery. The nanoscope system incorporates a 1.9 millimeter arthroscope with a 2.2 millimeter outer diameter cannula and chip-on-tip imaging technology, which provides a substantially smaller and more flexible arthroscopic system. Here we have a picture of the conventional endoscopic carpal tunnel release system. And then here we have a picture of the nanoscopic carpal tunnel release system. The overall purpose of the study was to compare the functional outcomes and reoperation rates following nanoscope-assisted carpal tunnel release and conventional endoscopic carpal tunnel release performed using the centerline system. And we hypothesized that the nanoscope-assisted carpal tunnel release would provide clinical outcomes comparable to conventional endoscopic release while facilitating favorable recovery of objective hand function and strength. So the methods, this was a retrospective comparative cohort study performed by a single surgeon on patients from January 2024 to 2026. The inclusion criteria included patients older than 18 years of age with clinically and or electrodiagnostically confirmed carpal tunnel syndrome who had failed conservative management. The patient-reported outcomes were the Boston Carpal Tunnel Questionnaire, Symptom Severity Score, Functional Status Scale, Quick Dash, and Visual Analog Pain Scale. Objective outcomes were grip strength and pin strength. The primary safety outcome was reoperation, and there were 60 patients in the centerline group and 200 patients in the nanoscope group. There was no significant differences in baseline demographics between the patients, and these outcomes were recorded at the preoperative period, 2-week, and 3-month period. So outcomes over time, you can see both groups, they had significant improvement from the preoperative to the 2-week and 3-month period in the symptom severity score, but these results were not statistically significant. The blue line is the nanoscope group and the green line is the centerline group. Similarly, for the functional status scale, there was improvement in both groups over time. However, these results were not statistically significant. Similarly, with the quick dash, there was improvement from the preoperative to the 3-month period. These results were not statistically significant. Visual analog pain scale, similarly, improvement in both groups from the preoperative to the 3-month period without any statistical significance. There was increase in grip strength in the nanoscope group from the preoperative to the 3-month period, as well as in the with pin strength from the preoperative to the 3-month period. There was a statistically significant difference in pin strength. In terms of reoperation, 3 of the 200 patients in the nanoscope group required reoperation versus 1 in the centerline group who required bilateral revisions, not simultaneously, but there was no statistically significant difference in reoperation rate between the 2 groups. So overall, between centerline and nanoscope, they both showed improvement in symptoms, function, and pain from the preoperative period to the 3-month period. Reoperation was uncommon between the 2 groups, and they were not statistically significant. And the take-home message here is that nanoscope-assisted carpal tunnel release, it's a minimally invasive, portable, lightweight procedure that can be suitable for office or procedure room use. They have outcomes that are not inferior to the traditional conventional centerline nanoscope or centerline carpal tunnel release system and its favorable safety and efficiency profile. I don't have a limitation slide, but there are several limitations to this study. First, the study groups were not matched, and they differed significantly with respect to baseline grip strength at the start of the study, which may have influenced the post-operative comparisons, despite similar improvements in other clinical outcomes. Secondly, there was an early post-operative period, so it may not capture any recurrent symptoms, delayed complications, or the durability of functional improvements over time. Third, there were unequal sample sizes between the cohorts, which may have reduced statistical power for certain outcome measures. And finally, important outcomes such as return to work, operative time, patient satisfaction, healthcare utilization were not analyzed for the study.
Want the presenters come up for questions? Dr. Vaquero, I have a few questions for you. First off, was this study sponsored by anyone? Arthrex, okay. How did you test grip strength and pinch strength?
I would have to speak with the author about, or Dr. Chewy about that. Yeah.
Okay. And final question, did you perform some of them in office or were they all OR?
For the centerline group, they were all performed in the OR, and then the nanoscope procedures were performed in office.
All of them?
Not all of them, but a large majority of them.
Oh, cool. Thank you.
Dr. Casco, did you sub-analyze by distal radius fracture in your study? I mean, those are the ones that tend to bleed a little bit more.
Yeah, no, we didn't. We weren't powered enough to glean anything from based on procedure. So we would have to randomized for a longer period of time in order to substratify. But that's definitely something we want to do in the future.
For Dr. Druskovich, did you guys measure the impact of time on your guys' patient cohort? You did talk about how other studies showed that it was faster, but did you guys see that yourselves?
We did not measure time in ours. We were just looking at the complications.
Yeah, our hand surgeons love doing this on the stretcher, and just anecdotally, it does improve the workflow.
For Dr. Devarasetti, how did you choose 10 minutes?
Yes, sir. So the previous two studies with both carpal tunnel and cubital tunnel that I'd mentioned in my study had also used 10 minutes, and they showed both biomechanical in addition to clinical outcomes with grip strength and pinch strength, and that they had also used the 10 minutes. And so that was the model that we'd used for our nerve transfers as well.
For Dr. Roger, how did you determine the complications? So they gave you a database and it had, tendon injury, neurovascular injury. It was all in the information they gave you?
Yes, sir. The ICD-10 codes for the group of postoperative complications that were gleaned from the data. Yep.
Cool.
For the link to the CPT code of the procedure performed. Yeah.
Oh, and so when you guys went through the data, did you do any subgroup analysis between people who identified themselves as hand surgeons versus general orthopedic surgeons?
We did not, sir. Not that I'm aware of.
Okay.
We're a little ahead of schedule, so we'll take a break until around 10:20. Thank you.
Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself. So it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself, so it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself, so it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself, so it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself, so it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself, so it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
you have to see things before you can do them yourself. So it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today. Are you looking for a valuable learning experience for your orthopedic residents? At OREF Resident Research Symposia, residents gain experience presenting their research to their peers and senior researchers.
I love having the opportunity to present and share my research and to hear what other Midwestern residents are doing.
OREF holds regional symposia throughout the U.S., co-hosted by prestigious academic institutions. Residents apply through a competitive process to present at a regional symposium, with top finishers receiving cash prizes and an invitation to the national championship. But it's not just about the prizes.
You learn a lot just from coming to the conference and listening and learning from others.
You have to see things before you can do them yourself. So it kind of opens my eyes to the possibilities of how my career can manifest.
Interested in co-hosting a symposium or having your residents present their research? Contact OREF today.
Back. We will move on to the pediatric section. Dr. Sweeney from Carolina's Medical Center, pediatric lateral condyle fractures, pins or screws.
Good morning, everybody. I'm Brian. I'm one of the PGY3s at CMC. I'll be talking about whether we use pins or screws for lateral condyle fractures. We have no disclosures. So lateral condyle fractures make up about 12 to 20% of pediatric distal humerus fractures, typically around ages 3 to 10 years old. Displacement greater than 2 millimeters is not well tolerated and generally requires surgical fixation. Despite pins and screws both being standard of care, there's no real consensus on which is the most optimal mode of treatment. Our hypothesis is that improved range of motion and no difference in time to union with screws versus pins. So prior mechanical studies by Schlitz and his colleagues demonstrated that in tension, screws were stronger than K-wires, providing greater stiffness and requiring more force to displace the fracture fragment. This gives us a reason to think that screw fixation might translate to better clinical stability. So our methods, this was a non-inferiority study, prospective cohort study at a single level 1 trauma center from 2019 to 2025, enrolling skeletally immature patients under the age of 18 with isolated, displaced type 2 or 3 lateral condyle fractures. Fixation types, pins versus screws, were based on the treating surgeon's preference. So our primary outcome was time to radiographic union. Secondary outcomes included clinical union, elbow and forearm range of motion, duration of immobilization, and complications. And we used the statistical analysis described here. So for our results, 66 patients were treated with pins and 37 with screws. Screw patients were significantly older at 7 years versus 5.5, and nearly all pin patients had their hardware removed compared to only roughly 54% of screw patients. And the screw patients had a longer follow-up. So from a functional results standpoint, patient with screws spent significantly less time in a cast, about 8 fewer days, with no significant difference in radiographic healing time. Range of motion showed small but statistically significant decreases in flexion, pronation, and supination with screws, though the total arc of motion was not significantly significant. And from a clinical standpoint, these differences were not important. Patients with, in total, there were 9 complications with pins compared to 3 with screws. Lateral overgrowth and non-union occurred only in the pin group. The complications in the screw group were a single reoperation and 1 case of elbow stiffness that did require manipulation under anesthesia. Overall, screw fixation trended toward a 64% lower odds of complication, though this did not reach statistical significance. We saw 1 case of capitellar avascular necrosis with the pins, and 1 screw patient that required revision for technical error. Both pin non-unions had undergone open debridement and reduction. So our data does kind of fit with the corroborated data from Cummings and colleagues that showed in 760 fractures, there was about a 2.2% non-union rate between the different fixation types, but they found that there was more elbow stiffness with their pin group. Existing literature, though relatively retrospective, does tend to favor screws. Gilbert and Stein both reported greater flexion and arc of motion, fewer infections, less non-unions requiring reoperation, and a shorter time in a cast to union with screws. So in conclusion, screw fixation gets patients out of their cast faster without increasing complication risks, with slightly faster radiographic healing and no clinically meaningful change in range of motion. So based on our low rates of hardware removal, routine screw removal may not even be necessary, which is an active thing that we're researching right now. So these are my references, and I appreciate the time. Thanks.
Thank you. Next up, we have Dr. Ofa from Tulane, Brace for Impact, comparing return to support and outcomes of ulnar collateral ligament reconstruction versus repair with internal brace.
Thank you. I'm Tiona Ofa. I'm coming from Tulane University in New Orleans. Just to provide some quick background information on the UCL, Prior to 1974, UCL injuries were treated surgically with repair. However, these had terrible outcomes. And then in 1974, Frank Jobe introduced the Tommy John procedure, which revolutionized the treatment of this. Fast forwarding to 2008, Dr. Salva reintroduced that repair could be possible with good outcomes. And then in 2015-16, Dr. Dugas introduced the internal brace, further reinforcing the repair and showing that rates of return to sport were high, at least in the short-term period. And so purpose of our study was to determine the return to sport and functional outcomes, complication profiles, reoperation rates, and patient-reported outcomes in both the short-term and long-term for both the UCL reconstruction patients and repair with an internal brace. Patient data was collected from 2013 to 2023 to ensure at least a 2-year minimum follow-up. You can see above our inclusion and exclusion criteria. Our return to sport outcomes that were measured were time to full range of motion, return to throw program, release to full activity, and return to sport. And we also measured the rate of return to sport and pre-injury level. Patient-reported outcome measurements were the same score in the ASCS elbow score. Complications, again, are listed above. And if a patient required a reoperation for revision, UCL, ulnar nerve transposition, or decompression, these were also reported. And then lastly, a standardized postoperative questionnaire was sent out to all patients to assess long-term pain, elbow function, return to play performance, satisfaction, persistent symptoms, rehabilitation course, and postoperative complications and or reoperations. There was a total of 155 patients included, 23 underwent reconstruction and 132 underwent repair. Reconstruction had an average clinical follow-up time of 11.7 months and repair of 16.3 months. For rate of return to sport and return to pre-injury level of play, both cohorts had very high levels with no significant difference between the two. And to summarize this slide, while time to full range of motion was not significantly different between the two cohorts, repair patients were found to start the return to program 4 months sooner than reconstruction patients. Repair patients were cleared to resume all activities 2 months earlier than reconstruction patients, and repair patients returned to sport almost 4 months earlier than reconstruction patients. Looking at this slide, the bar graph shows the different complications that were reported, all of which there was found to be no different statistically between the two cohorts. And in terms of reoperations, 6 repair patients did require reoperation, 2 needed a revision UCL reconstruction, 2 required ulnar nerve transposition, and 2 a decompression. And then reconstruction patients did not undergo a reoperation. The short-term postoperative recovery period, PROs, were not statistically different between the two cohorts. And then lastly, for our long-term follow-up results based off of our survey, we have faced some limitation with this aspect of the study. Only about 32.5% of participants in our study have completed this survey. Despite this limitation, these long-term PRO results suggest again that there remains no difference between repair and reconstruction. And so in conclusion, reconstruction and repair patients with an internal brace have similar rates of return to sport, return to pre-injury level of play, time to full range of motion, complications, and PROs. However, UCL repair patients had a much shorter duration of time before they could return to throw or release to sport and fully play. And while somewhat premature to conclude, the long-term results show that both repair and reconstruction patients are happy with their results. Thank you.
Next up, we have Dr. Childers discussing fresh meniscus allograft transplantation using a double bone plug technique results in an overall high 2 to 7 year functional survival rate.
Hey everyone, I'm Justin Childers. I'm a first year here at Orlando Health. Myself and my co-authors have nothing to disclose related to this talk. So why do we want to preserve the meniscus? So classically thought of as just a shock absorber. We all know the meniscus has a multitude of functions, including proprioception, cartilage nutrition, stability, and very importantly, load transmission. So seen here, the meniscus is able to convert axial load into the hoop stress, kind of preserving the cartilage on the tibiofemoral joint. This is obviously very important and even more important in younger patients. Seen on this next slide, as we lose more of the meniscus, more of that contact stress is reciprocated to the joint. And it's very important that we preserve as much meniscus as we can in order to prevent this. So what do we do in a healthy young patient who's symptomatic and obviously is not a candidate for arthroplasty? We have meniscal allograft transplant. So this is kind of a newer technique and is gaining a lot of traction over the past few years. Outcomes have shown, this recent study by Kunze et al. Looked at 5 and 10-year follow-up. It was a meta-analysis, so looked at kind of all the existing literature, and they had an 11% failure rate at 5 years, and that should say 23% at 10 years. So it's pretty satisfactory outcomes in terms of survivalship, and seems like it might be buying these patients some time. So currently there's no consensus on what the best technique is. Originally, a lot of people were doing suture-only fixation. Now it's trending more towards bony fixation, particularly a double bone bridge is one of the newer techniques that's getting a lot of traction. However, the current literature doesn't really support one method or the other. It's all theoretical based on biomechanics and things of that sort. Also, there's been some advances in graft processing. Previously, they used a lot of frozen allografts, and now they're using a lot of fresh allografts. It has a theoretical advantage of preserving cells and as well as collagen. The existing literature is pointing towards that, although I'll note that it's a low level of evidence, so we can't definitively say that yet. So the purpose of this study was to analyze fresh meniscal allograft transplant, particularly the failure rates and mechanisms of failure, as well as characterize risk factors and identify what variables we can address to improve outcomes. So this is prospectively collected registry data. All these patients had fresh allografts and used a double bone plug technique. The minimum follow-up was 2 years. We defined treatment failure as reoperation, so partial or complete allograft removal or revision mat, or conversion to arthroplasty. We also looked at subcohorts for sex, age, BMI, nicotine use, laterality, and concomitant procedures. We did this to identify which of these might be a predictor of failure. This image is also showing the double bone plug technique where you harvest on either end additional bone. So failure mechanisms are joint disease progression, graft tears, graft extrusion and shrinkage, as well as fixation failure. We were able to identify 61 patients with an average age of 33 years old. Mean follow-up was 47 months. So overall, we had an 88.5 initial graft survival rate, and we had 7 failures, giving us an 11.5% failure rate. The mean time to failure was 18 months. So looking at our failures, we had 7 failures. 3 of those required arthroplasty. 4 of them were able to undergo revision MAT, and 2 of those remain non-failures at 2 years. So our overall functional survival rate, meaning the ones who went revision MAT and then did well with that, were able to get us up to 92%. When looking at what factors predicted failure, we found that nicotine use and concomitant cartilage procedures such as osteochondral allograft transplant were the 2 main predictors that showed significance in which people are going to fail. So the mechanisms of failure identified in our study were 71.4% of our failures had joint disease progression, and then 28.6% had allograft tears. So overall conclusions from the study is we had a 92% survival rate for fresh meniscal allograft transplant. Nicotine and concomitant cartilage restoration increased the risk for failure, which obviously should be noted that those undergoing concomitant procedures likely had worse disease, and maybe we're going to do worse from the start. And then joint disease progression and meniscal allograft tears were our primary mechanisms of failure. Thank you.
Okay, if our presenters would like to come up for some questions. I had some questions for Dr. Sweeney. So you weren't electively removing any screws, is that correct?
We removed, I think it was around 40% of the screws around 6 to 12 months after. What we're looking at, kind of the next step of this project, is to see if that's actually necessary and if it affects growth of the elbow down the road. We found that the younger kids tended to have their screws removed versus the ones that are a little older, a little more skeletal mature. Our surgeons opted to keep those in.
Okay, so it was kind of just based on age, pretty much?
it's more so surgeon preference, but I think it trended towards an age and skeletal maturity.
Okay. Were you guys using partially threaded screws or fully threaded screws?
I believe
And-
most of our, we didn't necessarily look at it, but most use fully threaded screws, if I'm not mistaken. But again, surgeon preference. We kind of just comparing screws versus pins.
Okay. And how did you determine cast days? Because that can be, pretty subjective depending on when the patient follows up. So-
Exactly. That's one of the limitations. Typically, our pin group would come back at a week just for a repeat x-ray to make sure that the pins hadn't migrated or anything, and then follow up in 3 to 4 weeks after that, versus the screw fixation group, which tended to just follow up in about 3 to 4 weeks for one check. So that was a limitation to the study, is kind of routine follow-up for these patients.
Awesome. Thank you.
Justin, did you look at alignment and whether that influenced failure of the meniscal transplant?
So that's something that would be good to isolate going forward. Obviously, those patients might require osteotomy or an additional procedure. I think when we're looking at meniscal allograft transplant, it's in, a meniscus deficient, young, active, symptomatic patient, maybe not a high level athlete, someone we just want to buy some time for.
In that same patient population, if you get an MRI preoperatively showing cartilage defects with your high failure rate on those with the cartilage defects, would you recommend against meniscus transplant?
So something important is that if you look at concomitant osteochondral allograft transplant in those patients combined with meniscal allograft transplant, those outcomes in isolation are actually pretty good. In this study, the patients who had the isolated meniscal allograft transplant did better than those who didn't. But I think that's more reflective of, the symptoms that they're having in the disease progression. So I wouldn't necessarily, say that it's an absolute, but I think it's more indicative of we need a control for disease progression when we're looking at these numbers.
Dr. Sweeney, so have you guys looked at all the bioabsorbable screws? Or are you just using metallic screws right now?
Metallic now, but that's a great point. I think that's kind of something we should look into as we kind of trend towards that direction. Yeah, but we have not looked at that, no.
Yeah. And then Dr. Ofa, your study showed that using the internal brace got people back to sport and faster through their rehab. Is that a function of did they have a separate rehab program or then just the repair group? Or was that based on some milestones they had to hit along the rehab pathway?
They all had similar baseline milestones that they have to hit. There's just a difference in rates of when they're allowed to return to start activity.
Dr. Sweeney, I have a question. Were you guys able to look at outcomes stratified by the severity of the fracture type?
Not necessarily, no. It was either displaced or non-displaced, and then most, when you have a lateral condyle, will open it if needed. So severity was not part of the stratification. Our patient sample size was fairly low, so I'm not sure our numbers would have allowed that, but it's a good point.
Also, Dr. Ofa, a question. How was return to play and return to sport documented within the charts? Was it just verbal clearance and a follow-up note? Or was there a physical therapy documentation stating that they went through the program? How did you guys collect that data?
Both. So both the attendings that we got these patients from do a really good job of documenting that in their note, but then they also provide the physical therapy notes with clear description of return to play versus a return to sport.
Since we just had a break, we'll keep going and we'll begin the keynote talk. Yes, can we give them to you after the talk, or you want them now? Okay. No, you're welcome. Thank you so much, everybody, for coming. Thank you for OREF for including us and allowing me to speak today. Lots of excellent research topics presented today. I just wanted to give you a very brief talk on, how you can turn everyday clinical questions into high-impact research. We all know that you work 80 hours a week, 80 hours. You take call, learning very cutting-edge surgical techniques, but I want you to get something out of this talk on how you can present and get research published that is high impact. And so the resident myth is that you need a big, high-powered, multi-million-dollar lab in order to produce research that's of high quality that gets into JOS, JOT, all of your academy or organizations. But the reality is you just need to pay attention to what's around you and ask yourself why. And so you are the frontline people in orthopedics, and that's residents. And the ideas that you come up with end up getting published, and they make us as your mentors look very good. So over the next 20 minutes, we'll cover how to spot an idea in daily practice, choose the right study design to actually get it published before you graduate, ideally, and build a team to get it across the finish line. You have to mine your daily cases for ideas. You have to design projects that fit into your lifestyle. You have to have effective mentors and a team. And then you have to be able to get it over the finish line to publication. So for example, we're in Orlando. We have a very unique patient population. And so most of you are in places that are very unique. And so it was my first year in practice. I had a patient who was on the water slide in this volcano. She went down the water slide, she hit the water, and she had an open pelvic fracture. I was like, well, that's very odd. Do we have any other of those? And so then I looked and I found that we had about 5 or 6 of them. And so the case study was looking at theme park water slide injuries causing pelvic ring fractures. And we documented the mechanism, reviewed imaging. We talked about the treatment. It got published in JBJS. So very simple, just an idea how it can turn into a study. You can look at modern technology. Modern technology is also altering not only your education, but also how patients perceive orthopedics. And so a resident had a question, or actually he was a medical student, excuse me, is ChatGPT giving accurate information for patients who want to have arthroplasty? And so we came up with a survey, we sent it to ChatGPT, and we sent it to our faculty, and then we rated the responses of ChatGPT to simple questions that a patient would ask, how much pain am I gonna have? How long do I have to stay in the hospital? And the study actually did very well, and it was published in Advances in Orthopedics. So you can see, very simple idea. It can turn into a very effective study. Another one, you can question standard practice or dogma. When I was a resident, we were taking all open fractures to surgery immediately upon presentation, regardless if they were type 1, type 3, didn't matter. Went to the OR immediately. So here we tend to treat open fractures in the trauma room, 7:30 case the next morning. So we wanted to see if semi-elective surgical debridement of open tibia fractures led to increased infection rates. So we analyzed all of our open tibias. We determined the infection rates. We found that there was no difference. We got it published into JOT, and we showed that non-urgent treatment does not lead to increased rates of infection. And so you can see how questioning deeply ingrained dogma can yield practice-changing papers that improve patient care and orthopedic trauma surgeons' quality of life on call. So now there's data to support that you don't have to come in at 2 a.m. to debride an open tibia. Something else, when I first started here, there was a lot of intertrochanteric fractures being treated in the community. We got imaging on them. They came to see us for other reasons, and there was a big drop in quality between people who are not trauma fellowship trained and those who were trauma fellowship trained. So we wanted to analyze that. So we looked at all of the fractures that were treated within the health system between trauma-trained surgeons and non-trauma trained surgeons, and we did find a big difference. So trauma surgeons, expectedly, have better post-operative outcomes, radiographic outcomes of hip fractures. This was published in the Academy Journal, and now there's justification for shipping hip fractures to a trauma center to be treated by a trauma surgeon. For you guys, medical education and digital recruitment. So I was going through the fellowship match, like many of you guys probably are right now, and I was going to fellowship websites to see if I could get information on trauma fellowships. The websites were absolutely terrible, and I got almost no information, so I decided to do a study on it. So I went on all the websites for trauma fellowships, and I found what data that they were showing. And I found that there was a very big dearth in content, navigation, accessibility, and key criteria. This was actually published in JBJS. This is probably my most frequently cited study of everything that I've published. This is probably my most frequently cited study because it prompted other people to look at fellowship websites and other subspecialties, and even other specialties outside of orthopedics. So just by going through something as simple as a fellowship match, you can get an idea and make a study out of it. Cross-specialty gaps. I had patients who had pelvic fractures who were female, and they were coming in, they were pregnant, they're saying, oh, my OB tells me that I need a C-section. And they didn't have any reason to need a C-section. They had no implants crossing their symphysis. So then it's like, are all OB doctors recommending C-sections for people with pelvic implants? Yes, they were. So we sent a survey out to OB physicians in the US, and a vast majority of them had no idea what any of the implants were, or whether or not the patient should require a C-section or not. And so we published a study investigating what OB surgeons thought about pelvic implants. And so this cross-specialty communication can be very effective to alter practice patterns, not just in orthopedics, but in other subspecialties. Again, another study on fellowships. What do program directors look for in orthopedic trauma applicants? We sent out a survey, and so now we know what orthopedic trauma fellowship directors look for. And so when you're applying for orthopedic trauma fellowship, you know what the important things that fellowship directors look for, so you can tailor your application towards that. Another one was looking at what trainees look for in fellowships. So we were able to tailor our fellowship. We sent out surveys to people going through trauma fellowships, and we found what's important to them. We published it in JAOS, and now trauma fellowships know what applicants are looking for. So just very simple things that you come across in your daily lives that can turn into effective research projects. And so this is probably the most important slide that I'll show you today. Choosing high yield study blueprints. And so maybe when you're a resident, a double-blinded multi-center trial is not the most effective thing. You may not have a chance to complete it in 5 years. It might take too much of your time. But a systematic review that you can do on your own time, or a meta-analysis, requires no IRB. You can do it, whenever you have 15 minutes in between cases, or an hour and a half between cases, or on your weekends. You can get something like that done in 3 to 6 months. We have a resident here who can do a systematic review within a weekend. He's very effective at that. And so the other nice thing about systematic reviews is they're very highly powered usually, and they're cited very frequently. So if you want to get your name out there, do a systematic review on something. If you don't know how to do a systematic review, there's many AI platforms now that will give you the exact steps on how to do that. You can do a retrospective cohort series like the waterside injury. If you guys, if you're in Charlotte and you have a very, NASCAR crashes or some things that other people don't have. If you're in Miami, F1 crashes, something unique that not everybody has. That tends to be good research that's very frequently cited. It's a very low time commitment on your part. You do need to get an IRB, but you can get something like that done in 6 to 12 months. And if it's unique enough, you will get cited. If there's a surgeon in your practice who does a very unique procedure that's not done nationwide, you should write about it. Go talk to that surgeon, get a list of patients, get his technique, take pictures. This is very high yield for surgical trainees. and for people who are looking for something unique. And again, the multi-center prospective trial, though it might have the highest impact, is probably not the most feasible thing for you to do as a resident. It's very difficult to finish. There's a lot of hurdles, and you need to find something that you can get done. And so this is the PICO formula. I've been told this multiple times throughout my time. And so P is the population. So before you pull a single chart, frame your idea into this. So a bad question would be, let's look at all of our distal femur fractures. But a good question would be, does adding a lateral plate to a retrograde nail improve healing rates of distal femur fractures? So clean questions can get you good data and quick write-ups. You have to look at the intervention. Are you using a novel implant? Are you using a new surgical technique? You have to have a comparison group. Now, most journals do require a comparison group. So level 4 studies are not being accepted much anymore. If you want to be in a high impact journal, you need to have at least a level 3 to have a comparison group. And then you have to have clear outcomes. You want to look at radiographic alignment. You want to look at something like lag screw slide, something objective that you can put a number on. And then the most important thing you need to have is a team. So if you're an intern or a second year, go speak to your senior residents and see what you can help them with. If you're a 3 or a 4, you're in the execution and statistics development phase, and you have to do the primary writing. If you're a chief, you can come up with an overview and polishing the manuscript. And as attendings, we usually come up with the ideas. We give you a strategy. We tell you which journals to submit to. And so all of these things, you see how it takes a team. Nobody doing all of these steps alone is going to be successful or prolific. And so you're all very busy, and you have to manage research, residency, and your life. And so if you batch tasks during non-call rotations, if you know a rotation, you're going to have a lot of time. Make a list of the things that you need to do to get your research project done. If you have, this is something very simple. One of my residents was like, I'm drinking way too much caffeine. He's getting palpitations. We did a study on it. You guys drink way more caffeine than the general population. It got published. You have to focus on quality over quantity. So residents think that they need 10 papers on their CV to get good fellowship interviews, and that's not true. If you have 2 to 3 very good focused papers that are actually published, it beats somebody who has a CV of 15 pending projects. So having at least 1 or 2 projects that are done and published will get you more notice than somebody who has many projects that are not published. And so in conclusion, just keep your eyes open, be inquisitive. Your daily frustrations are probably good research opportunities. If you're running into the same wall over and over again, it's very likely that many other people in this room are running into the same wall. So do a study on it. Pick study designs that fit your time constraints. Like I said, systematic reviews, retrospective studies, and technical notes are very good. Build resident teams across class years. So even potentially after you're graduated and have moved on, if you have a study that's still moving along, you can get publications from your institution after you're gone. And research is not really just a CV filler. It forms a foundation of how you will practice. If you want to go into academic medicine, you have to be able to show people that you have been successful. There's nothing more disingenuous than an applicant who says, I want to go into academics, and they have 0 publications. So if you want the job, you have to be able to perform. I really appreciate your time today. Hopefully you got something out of this. Any questions? Please? Anything? Yes. Yes.
I think one of the hardest things I've found in residency is that we have a bunch of good ideas that come up from our attendings, and we kind of start these projects. Do you have any kind of recommendations or pearls to actually get them across the finish line? It seems like a lot of them kind of make it through halfway. We get halfway through the data set, or the data is not kind of sufficient enough to identify or answer that question, but potentially it's something else. I'm just curious what your thoughts are.
Yeah, so that routinely happens. We'll tell you, oh, I have, this is a very unique injury. I have 50 patients of them. You do the data collection, you have 10. Just, if it's not going to lead somewhere, just kill it immediately. Don't keep it, dragging on and then you're like looking and it's always in the back of your mind. If you reach something that you don't think is going to be publishable, or if you don't have as many patients as you think you have, there's no harm in saying, we looked, it's not going to work, move on. So only dedicate your time to things that you actually believe will get published. Yes?
Yeah, I think to that point, where it usually fails is in the follow-up.
Yes.
So the residents will start, good idea, they look through 200 charts, get all the demographics, measure all the x-rays. The last thing they do is look at the follow-up, and they have one week follow-up on 80%, everybody's gone. All of that's wasted. So that may be one of the first things you do is get a number of people, see if it's a big enough series. And if there's 8 other series that are bigger, don't waste your time. So it is a little bit of fishing, but the follow-up's what kills us most of the time. That's the hard part.
And also, it was very, very, it happened to me. Like you have a lot of faculty who say, hey, we should look at this. We should look at this. Actually look at your faculty and see who are the ones that actually do get projects across the finish line. As attendings, we all want to be a part of research, but we're busy as well. So find mentors that actually have a track record of publishing. And those are the people that will help you get something over the finish line. My residents always have to keep me on top of things because, again, we're busy. But don't be afraid to reach out to your attending and say, hey, I have this. Can we meet? Just to keep moving the project forward. But always pair yourself with people who have a proven track record of getting research published. And that will help. Yes?
How do you balance being clinically busy with also doing research on the side, especially in situations where you're not necessarily get paid for doing that, up front. So you're not in practice and you want to prioritize having a busy practice, but you also want to contribute to research.
Yeah, so that's where the team comes in. And so if you can rely on your team, it makes your job a lot easier. The tasks that I have to complete for myself, you just have to find times within the day. So like I said, turnover time. You have 30 minutes. Are you just gonna, go down to the cafeteria for 30 minutes and hang out? Or are you gonna, get out your computer and make some edits to the manuscript? 30 minutes to sit and do something uninterrupted is a long period of time. So we're all very busy, but we all have little fragments of time throughout our day that you can utilize to be effective. And so I try not to waste any of my time. If I'm during turnover, my computer's out, I'm doing something to remain productive. Also, I wake up pretty early. We have young kids, and so you just have to find the time. Most of the time that comes at the expense of sleep, but it's worth it in the long run, I think. Yes?
Yeah, is there a blueprint that fellowship directors look at when they're considering applications programs to relevance to research that they're working?
Yeah. So the study that we published for trauma, the most important thing to fellowship directors was the actual interview. And so once you get the interview, it's much different than residency. So in fellowship, we're looking for a fit because all residents have similar training for the most part. You're all going to be very technically sound. Once you get the interview, it's all about fit for the program. Are you looking for the same things that a fellowship is offering? And as the fellowship is looking for what you're offering as an applicant. Getting the interview is the challenge. And so getting the interview is the rec letter is very important. And then the academic institution from which you came, and then your publications. But the two most important things are the interview, followed by the letters and the relationships that the fellowship faculty have with your residency faculty. Yes?
Outside of being an academic orthopedic surgeon and dealing with residents and fellows like yourself, what other doors have you found that research has opened for you in your career?
Definitely industry, for sure. Industry wants people who are clinically busy, but who are also publishing research, because you're just going to be a little bit more, your word is going to have a little bit more punch than somebody who's not. It may not be true. It doesn't make you any better. It doesn't make you any better technically. It just gives you a little bit more credibility.
Do you find that your patients value your publications and your research work?
I don't think many of my patients can read. So no. Yeah, most of them don't even speak English. But yeah, I do trauma, so that's why. Yeah. but it would be nice. Cody, do your patients appreciate it? He has a little bit more of a.
I saw your paper on this, I saw your presentation on this. This is what I have, but it's 10%.
Yeah, so it exists. Yes.
I saw one of your bullets on there said quality over quantity, and I know with the explosion of like database studies in orthopedic research over the past 5 years, it's kind of had a lot of people pumping out probably low quality research. And so what I wanted to ask you is, what's your definition of quality in that context?
Yeah, I think when you're talking quality in research, it's just pretty much which journal your paper is published in. Because when somebody's reviewing your CV, most of the time they're not going to look up your paper unless they have a particular interest. But if I'm reviewing somebody's CV and I see a JBJS publication, even if it's not a trauma paper, I'm going to think that that's a high quality study. So I think mostly just the journal that it's published in at this stage. Yeah. Any other questions, comments? All right, I hope you guys had a nice day. Thank you all for coming, and we hope you have a safe trip home. Yes. Great. Let's see who won. Yes. All right. The moment you've all been waiting for. All right, we'll start off with the honorable mention. That is going to be Dr. Catherine Druskovich, Table versus Stretcher, a prospective randomized trial. Congrats.
Thank you. Thank you.
You're doing
We need you to
individual.
stand with them again. Now, the rest of you know how it's
All right. Third place.
There's another honorable.
Second honorable mention. Dr. Ofa, Tulane University, Brace for Impact, comparing return to sport and outcomes of UCL recon versus repair.
It's a mouthful.
All right, congrats. Now we'll go to third place. Yeah. Third place is going to be Logan Reed, who had to catch a flight, unfortunately. So we will give this to him. All right. Second place, Dr. Graham from Carolinas Medical Center, can chronic antibiotic suppression after two-stage exchange arthroplasty prevent failure. Congrats. Of course, thank you. All right, and first place, and the $1,000 goes to Dr. Deborah Setti from Carolinas Medical Center. Does 10 minutes of intraoperative nerve stimulation to improve outcomes. And last but not least, the presenter's choice goes to Dr. Griffin Rector, primary total hip arthroplasty via the direct anterior approach for displaced femoral neck fractures in non-geriatric patients. You want to give this to Lauren? Of course.
Everyone who got an award needs to see Carmen and give her a mailing address because that she can send the check to. So if you want your money, see Carmen. And the first place, second place, and third place winners are now invited to participate in OREF's national competition, which will be on November 18th. It will be online in the evening. So you'll be getting additional information about that, but you will be the representatives from the Southeast region. And I congratulate all the winners, but I also want to say that I thought all the presentations were great, and I thank you for participating on behalf of OREF.
Yes, thank you, everybody. Thank you to the presenters for taking time, or the presenters for coming, and the judges for taking time out of your practice. Thank you.